you think very differently or you educate your referrers, you won't be able to find this. Um, People say it is rare disease. It is rare, but because it is rare, because people are not finding it. So, what are the investigations we do? The simple and straightforward investigations: X-ray, chest, and trachea. It might give you some idea about narrowing in that, particularly cervical part or laryngeal part. CT scan is important investigations, and laryngoscopy and airway endoscopy is a mandatory investigations, or is a part of the bronchoscopy. And pulmonary function test is one of the useful information which gives you whether it is obstructive disease or restrictive disease. There are fancy instruments like 3D animation. It gives you more realistic image from the kind of pharynx down to the carina. This is a case one. If you look at this very clearly on the first image, you start seeing these vocal cords, but this is subglottic area, but down below, certainly that is not normal for 50-year-old women. And but after the stenosis, if you pass, then you can see the normal tracheal rings and you can see the carina. So that will be your kind of normal circumference of the 50-year-old women. But what we have done in this case particularly, we used a balloon dilatation, and that's temporarily, it opens up. Clearly, it shows it is a soft stenosis. So it opens up nicely. But sometimes it could be a hard stenosis. In that case, the problems, the balloon dilatation won't give you a best kind of treatment response. So in general, for tracheal stenosis, there are different types of treatments. You don't need to jump into tracheal resection and reconstruction all the time, but it is a very useful and successful treatment with excellent long-term results. You can temporarily buy time by using laser surgery. It's a good short-term results. For example, in dividing the scar, or even if there is a tight stenosis, it just gives a radial cut. Then you can combine that with the balloon dilatation. It stretches nicely. Tracheal dilatation is not a new, but it probably is new because of the balloon. Previously, there were kind of metal tracheal dilators or bougies can be used, but the balloons are better than the tracheal dilators because balloons gives an expansion like in that direction, but the bougies and other things, it's kind of shearing force that causes more trauma. But balloons are is expensive. I think somewhere around costed 150 UK pounds, but prices are variable in different parts of the world. Tracheobronchial airway stent, it is available, and also it's a debatable type of treatment. There are a variety of stents available: metal, silicone, hybrid, tubes, plastics, things. But you can insert a short-term or long-term basis. But I'm not a big fan of these stents because of various reasons, like causes granulations. Maintenance is a difficult issue. Also expensive. Sometimes a stent can migrate. So this is a kind of overall treatment options for this kind of thing. This is a beautiful picture. This is a second case. You can clearly see, everyone can see the tongue base. This is the epiglottis, and you see the true cord, a ventricle, false cord, and 5 centimeter below. This is a subglottic region. You can see the cricoid cartilage, and that's a posterior ring. And roughly from the vocal cord, 5 centimeter below, there is a kind of stenosis. It's clearly seen. If you look at this history, this is a 27 years old woman who wants to get pregnant and had a road traffic accident 15 years ago, and she never had any tracheostomy. So she was actually managed in Romania by long-term intubation. And the long-term intubation is the one of the main cause for the tracheal stenosis. You can temporarily buy time, but anything more than 2 weeks, that could potentially cause long-term stenosis in future. That's worth keeping that in mind. Her symptoms are exertional dyspnea. When she goes for jogging or going up to the flight of stairs, and she becomes breathless. And she was worried when she became pregnant. There are a lot of physiological changes. She become more pregnant. She become more breathless in a heavily pregnant, maybe third trimester or fourth trimester. So this is our picture before. What you can see clearly, beautiful vocal cords, ventricle, and you start seeing this stenosis. This stenosis is actually a tight stenosis. Unlike the previous case, I have tried with a balloon dilatation, but it wasn't stretching much. Actually, there was a cut with a laser. You can see that one, and it did buy a time for her, like 6 to 8 months. She was symptom free. Then she became slightly breathless. I usually assess them by giving the PEFR, which is readily available at 10 pounds in Amazon or other things. A normal PEFR flow, you can just blow it through the mouth. That normal adult people will have a 450. For this sort of people, they will have only around 250 to 300. That itself gives you a prognostic kind of marker, and also your assessment of the treatment objective. You can measure them in an objective way. So this is adult tracheal reconstructions. And while you're planning these cases, you need to find out what is the length of the, for example, length of the tracheal stenosis. So it's roughly around 2 centimeter, the soft tissues, and it is involving only the cervical trachea, and she has got a nice long thin neck. This is a first and foremost important finding: how bad the neck is, whether the patient is obese or not, whether the cervical spine, they have any rheumatoid arthritis with this flexed posture. So these are all the difficult cases to do. So this is a straightforward case to start with the beginners. So you can see the long thin neck. I just marked the thyroid, cartilage, and the cricoid, and I just marked that area of the stenotic segment. I just matching with that CT scan. So it's a straightforward procedure. I'm just making a cervical incision, raising the flap above and below. I made a smaller incision, but you may have to make it bigger in certain situations. Very similar to tracheostomy, and stay in the midline and divide the midline strap muscles. I don't need to resect any strap muscles, just separate and retract it, and you will be straight into the trachea. If there is any thyroid isthmus, you may have to divide it. So it will be scarred, and it's not like a normal tracheostomy, or it's because of the previous trauma. You will see there is some fibrotic tissues, but you have to kind of very close to the cartilage or tracheal rings. Right away, you can see after the dissection, you can clearly see this is a normal tracheal lumen. This is a kind of nicely bend, like a dimple going down there, an abnormal shape coming up. And you can clearly measure from its starting from kind of a 3 centimeter, it's abnormal trachea. So that's the tracheal stenotic part you can identify through your dissection. So the next is planning the surgery. I'm just giving you planning the surgery, but you should have had a good plan well before the operation. So what are the plans you can make? The first plan is it in the cervical trachea, or is it going down to the thoracic trachea? If it is going down to the thoracic trachea, it's clear you should have a thoracic surgeon with you in your institution, or a thoracic setup is mandatory. And next thing is, what is the length of the stenosis? Am I going to resect myself and reconstruct myself, or do I need to open the chest? For example, if it is up to 5 centimeter, in my experience, you can resect and mobilize the trachea above and below and reconstruct primarily. If anything beyond 5 centimeter with comorbidities like really short neck, very obese neck, and damage in multiple areas, you're actually looking for a bigger procedure. So multidisciplinary team working is essential in those cases. So once you've done that one, you started skeletonizing a bit more, but you don't need to dissect too much down for mobilizing both areas. At this point, I'm just going to go down into the thoracic trachea to mobilize, free up a bit more. Technically speaking, you don't need to go too much downwards. And the next thing is, this is a further down. You can see this is the foot end, this is the head end. I'm going a bit more down with a good lighting and changing your posture to mobilize around this trachea. And then I'm thinking most of these actions are a blind and also finger probing action. So you have to be very gentle and slow because this is the mediastinal areas sometimes, and there are abnormal vessels. So you need to be very slow and bloodless and make sure you're using a gentle pressure, not too much blind cutting. So once I have done the lower resection, lower mobilization done, and I was just trying to use my gentle pressure, how much mobility I can achieve from the lower part. So usually if you dissect around the lower part, you can get a 2 centimeter length up. But I assessed this segment was nearly more than 3 centimeter, and I felt that I needed to release the suprahyoid release, which is actually releasing a part of the inferior constrictor and finding the thyroid, and above is a hyoid bone. The hyoid bone is one of the important bone, which is hooked up by the suprahyoid muscles to the chin or the styloid process or the tongue. So if you release those muscles, but probably if you do this, the people who does the thyroglossal duct surgery, it's exactly similar way. So go or laryngectomy, similar to the laryngectomy, use the monopolar and skeletonize the hyoid bone and release the suprahyoid muscles just above that. But unless laryngectomy, you don't need to mobilize the whole hyoid bone. So all you need to do is you're going to cut the mid portion of the hyoid bone, so that you're not removing it like thyroglossal cyst, just cutting it so it just pulls down. So that's what you need to do, that one. So you've done the both mobilization of the suprahyoid and also the lower part of the trachea, then the resection part. So how do you do the resection part? So you see that I cut in the middle of the stenotic segment, because the aim is to achieve the normal circumference on either end, right? So you don't want to cut here and you find out, oh, that's normal one. Why did because it is more like a conservative approach. So I cut the middle. You see that one, how thick it is. Even the trachea, the normal thickness is actually maybe 3 millimeter. This is actually a centimeter trachea. And that's how it happened because of the trauma and the stenosis. The whole thing is becoming hard as stenotic segment. Then this is not going to get better with your laser or with your balloon dilatation. This is a fixed, hard stenosis. So what I have done, I made a first cut. Then I'm looking for the second normal trachea. I made a second cut. Then I looked through underneath. Then the stenosis was extending. To be honest, actually, I started with the 2 or 3 tracheal rings, but I ended up removing 5 tracheal rings. My heart rate kind of went up. I wasn't kind of keeping thoracic surgeon on the backup, but textbook says if you're resecting 5 rings, the suprahyoid release as well as the tracheal release, and also you need to go to sternotomy and do that one. The textbook always says few things to kind of frighten you, but that's not always true. And this is we need to come out with this kind of fear for this stenosis treatment. So we mobilized above and below, because I told you earlier, this lady has got a thin, nice neck, and what we've done is we've resected it, and you see the defect. It's actually large. When you resect it, it seemed like a tracheostomy. It just opens up widely. So I did a further mobilization. You can see that the hide has been completely released, and then the suturing bit. All you need to do is just try and mobilize and just see whether this both comes together without much tension. I mean, much tension means you always get some tension, but you don't have to kind of, as long as it's not kind of ripping through, you don't need to worry. So how do you suture it? This is one of the beautiful technique. This is the way you need to use your plastic as well as reconstructive skills. You need to literally calm down, spend enough time for this patient, don't overbook the cases, and start beginning the suturing. It's like anchoring. You're not doing one by one. So you need to leave the sutures with the multiple sutures you need to choose. The reason is once you start tying one by one, then it'll become kind of rip through. That's why you make all the stitches, but don't tie it. So how do you do that? There are so many things you can talk, to be honest. To be honest, this tracheal tissue is one of the best healing area. Whatever you do, it heals up beautifully. But you have to use some good surgical principles. So try to keep the knots on the outside. So that's your mental calculation for a sutures. Start from one side and come kind of all the way around it, or start in the posterior aspect on both sides and bring it together closely that way. So, and make sure you kind of mark it properly in a kind of mental calculation. Otherwise, if it all kind of crossing each other, that causes confusion, which you don't want to do that. So do it in a very calm, composed environment. Then bring the sutures one by one together. And at that point, make sure your neck is completely flexed and there's no tension between. Sandbags should be removed, the head should be raised, and so you bend your neck, patient's neck, so that everything it comes together. This is the 5 rings we resected. It's all coming together. On you can see is all simple interrupted sutures with the vicryl, which is with a round body needle. That's very important. But you can also use monocryl. Some prefer, I sometimes alternate with the monocryl and vicryl. Monocryl give a better needles. Vicryl also gives different strength. Then I use a T-seal, which is a hemostatic fibrin glue. And then close that with a free drain. So I don't use any suction drain. This is a free drain. It's not for hemostasis. It's just for if there is any surgical emphysema, if the patient coughs or something like that, that to prevent that one, we keep that. It's a H free drain. And also after that, before closure, just this point, we put some water in it. And we asked the anesthetist to put some high pressure Valsalva to find out any air leak. And then we close the wound.
My name is Kasia Rose, and it's 7 days since the operation, and I'm feeling fantastic. My breathing improved a lot, and I have no difficulties with eating or drinking, so I'm very pleased and happy, and yeah, I think that's it.
So what operation you had?
It was tracheal resection, sorry.
Okay, that's great, thank you. Immediately after the operation, you saw that the stenotic segment, and you bring them back, or giving them a normal trachea, they feel actually refreshed, and their voice will be more stronger because of this more air reserve comes out. and they back to kind of normal flow. This is another case. This is case 2. You can see that this is a little bit tricky, and they even present this with acute stridor, or particularly the kind of chronic stridulous patients. They present with acute stridor when they have upper respiratory tract infections, or this sort of patients. Actually, this patient was referred from respiratory team. This patient was admitted in ITU with a recurrent pneumonia more than 4 times in a year. Then they did the bronchoscopy. Then they found this out for this patient. So respiratory people are one of the main source of referral, or ITU team should be your kind of main area of education. The reason I'm putting this one is to review the scans. You need to develop that skill to how to review the scan. This is a normal trachea just below the subglottic area. You can see the thyroid cartilage. And this one you see started narrowing. This is clearly abnormal in this area, and even further down cuts showing more narrowing. And this is a parasagittal view. It gives you the length of the stenotic segments. You can measure it, and this is the last picture. It shows how it's like kind of tip of the some kind of arrow. It clearly matches your endoscopic picture. We did try with a balloon as a kind of first starting point. We always, these patients goes for a diagnostic airway endoscopy, and it straight away use a balloon. And then we don't do surgery straight away. Then we come back and reassess the situation. And then usually the surgery is usually carried out after 2 or 3 balloon dilatations, and because we are giving choices to the patient. So if you look at this stenosis, is a completely different stenosis. This is caused by previous tracheostomy by ENT surgeon, actually. This patient had some kind of a stroke and ended up in the ITU 2 weeks later. She was referred to surgical tracheostomy. Most of the times they do temporary percutaneous tracheostomy in ITU, but this case they referred it for surgical tracheostomy, and that caused a problem 2-3 years later. That caused a stenosis. So what did we do wrong in the surgical tracheostomy? The previous surgeon removed a big window for that particular case. So I'm dead against doing, while doing tracheostomy, if you do a big window, that is, you're not doing anything good for this patient. So I always make a vertical slit and use 2 stage sutures to open that trachea. So that could potentially prevent future tracheal stenosis. You don't see many, but when you are in the center doing a big tracheal resections, and you see invariably 2 out of 3 because of previous surgical tracheostomy done it in a poor manner. And this is, you can see that one. This is a another abnormal picture. You see it's narrowing here, and it is really in a very abnormal shape. So we have to resect like 3, 4, and her neck was not a best neck. I wanted to show this one. See this, how much a big fat pad, a short neck, rheumatoid neck, and there is no neck like that. This is a difficult case to do, and previous surgical tracheostomy as well. So, and one point, the reason I put this slide is anesthesia. So how do you give anesthesia? How do you work around this tube? Normally, you can use micro tubes to pass this, to get past this tracheal stenosis. Sometimes you can't even put the tube in. So you may have to use the tubeless techniques, or just before the surgery, you have to use the balloon dilatation, then stretch it temporarily, then pass the microtracheal tube. Then you have to kind of work around the tube. That's the trickiest part here. So the stitching and other things, you have to go around it. For this particular case, while cutting it, we just damaged the balloon. So we were temporarily using the temporary intubation from the lower end. Then this is a guide wire actually coming from the top end. And then once everything was resected, we put the endotracheal tube through that, and then we stitched over that. I don't use any stents. and stents are not necessary at all. So this is actually immediate post-op pictures, because once you see that's a suture line here. So it gives you from this state to this state within hours. So the patients immediately feel a lot better with that. So once we done the reconstructions after the procedure, we look through the endotracheal tube. The endotracheal tube is being pulled up to the vocal cord level, and you use the fiber optic scopes to have a look how see. And these patients, all of them, if you're satisfied with the airway, all been extubated on the same day after the procedure, and patients being sent to intensive care unit for 2 days just for observation, then back to the ward. And we don't keep them intubated for 48 hours like some textbook says. It's not necessary. And I don't use any chin tuck incision. It's simple post-op instructions not to overstretch. That's the main thing. This is just to show you whether it is coming back together. So that's how, if it is all coming back together, that means you are winning. That's what you need to check. Where it doesn't matter how big you are extending your incisions are. So I think pretty much it is another case, slightly different technique. I have not removed it like a kind of full rings. This I have removed like a kind of partial V-shaped, because I knew that was coming together nicely. So you don't need to be like a kind of textbook, it clearly shaped, step shaped or something like that. Your idea is inside lumen should be decent enough and should be bigger than the previous stenotic segment. So in summary, tracheal resection or reconstruction is a multidisciplinary multidisciplinary approach, whether it is for diagnosis or it's a treatment. You need to include a proper experienced airway anesthetist, and it's a good surgical outcome. In difficult cases, there is a lot of extension, then you should involve cardiothoracic surgeons with a good intensive care unit who can back you up. And I think that's it. I'm happy to take any questions.
So Jay, that was an excellent presentation. Really enjoyed it. Great photos. It felt as if we were all in the operating room with you. That was fantastic. Now, in keeping with this, with the format for this web series, we will keep the questions to the very end. And I would like to invite the next moderator, Dr. Sajid Babu. He's a well-known head and neck oncologic reconstructive surgeon practicing as the head of department at Malabar Cancer Center. He is a national faculty for head and neck surgery and especially for reconstructive work. And it's a pleasure to invite Sajid for moderating the next session. Over to you, Sajid.
Thank you, Dr. Diwakar. I have the privilege to introduce the next speaker. She is Dr. Prabha Yadav. Needs no introduction to this forum, and she's a well-known internationally and nationally. Madam is currently the head of plastic and reconstructive surgery at Reliance Foundation Research Center in Mumbai. She was the main backbone of establishing a very well reconstructive department at Tata Memorial Cancer Center, where she was working for about 13 years till 2018. Madam was also working as associate professor at JJ Hospital, Mumbai. She is actively involved in teaching, and it's surprising, or it's very good to hear that she had been training. She had trained about 150 reconstructive microvascular surgeons from India and abroad. She also worked as president of Association of Plastic Surgeons in India and had published a book on mastering cancer reconstructive surgery. She has vast experience and is the right person to deliver the next talk on reconstruction of cheek and mandible. We are eager to hear from you, madam. Over to you.
Thank you for the kind introduction, Dr. Sajid Babu. How do I share the screen now? Yeah. So my topic today is I'm going to talk on the cheek and mandible reconstruction. Okay. The slide is not moving forward. The slide is not moving forward. What could be the reason?
Move your cursor to the left side and make sure that in the PowerPoint it's in the arrow. Please, madam.
Ma'am, and the corner you can see the cursors, the small white dots. Bring your cursor down, ma'am.
This?
Yeah.
This corner.
The left down corner.
Left down corner, you can see, yeah, that is next one, next button, next one.
Okay.
Yeah.
Yeah. See, more than 90% of oral cancers are squamous cell carcinomas. I mean, that is, I think, the most common cancer after breast and cervical cancers in India. Usually diagnosed from lesions which are represented usually on the mucosal surface. Any oral lesions that does not regress spontaneously or does not respond to usual therapeutic measures up to 2 weeks should be considered as potentially malignant. That's the dictum that we follow until proved otherwise by histopathology. So these, I think I don't have to go in detail about excision. What are the principles of excision? That is the white local excision with negative margins. That's the surgery being the primary modality of treatment for most of the head and neck cancers. And these surgical excisions may result in two variable defects. They could be small to large, they could be superficial or deep. They could be only soft tissue or only bone, or it could be combination of bone, soft tissue, bone, skin, or involvement in adjacent structure, like if you take it in the oral cavity with the mandible and the cheek skin, maybe the tongue also is involved. So these defects will be variables. And the requirement in onco is you need a primary wound healing in a stipulated period of time, because the adjuvant treatment needs to start in time if you want to complete the whole treatment. If you cannot start that in time, will not be able to start in time, then there will be a failure and there will be recurrence. And along with this, you need to preserve and restore the function, because head and neck, though it is a very small portion of the body, it is functionally and physiological aesthetically is the most compact region of the body. The restoration of function becomes very important, and aesthetics are equally important because face is our identity to the society and that gives us our self-esteem. So the whole treatment aim is ultimately towards quality of life, whether it is going to be 3 years or whether it is going to be 10 years. I think that's our main aim. So buccal mucosa and lip. See, mucosa is stretchable, which you can stretch and it recoils back. But that sort of tissue is not there in the body. But we need to replace whatever is replaced with a skin. So your aim is to have an adequate mouth opening. You can't close any defect primarily and heal it. But if it's not able to open the mouth, that is not what we aim for. And equally important is oral competence, because sometimes it may not be an isolated buccal mucosa lesion, it may involve the lips. So one needs to take care of the oral competence. And like I said, aesthetics are very important. So if we put a buccal mucosa, small defects, we have 1 or 2 centimeters, we can always close it primarily. I will not talk about small local flaps inside. If you put a skin graft, the initially on table it will look nice, but later on the patient is bound to develop a trismus. Whenever extensive intraoral defects are there, like this person, this is almost the whole lower jaw and the buccal mucosa is involved, but this is superficial. So this has ended it into marginal mandibulectomy with buccal mucosa excision from almost one RMT to the other RMT. So it required a thin pliable flap. So this is what is a big radial forearm flap. This is a well settled flap from this region to this region. And that's the competence. Another defect, similarly, but it was extending from buccal mucosa, RMT, going onto the palate on one side, except small raw area on the palate, similar lesion on the opposite side. So what we have divided, we have taken a design like that of the radial forearm flap and then reconstructed it, and pedicle came down on one side. So this is how is on the left side, this is on the right side. So pedicle, the whole flap had gone on the palate and then come down here from one RMT buccal mucosa to the other side. As the defects are anteriorly, your requirement is thin pliable flap, whichever you can take, but most of the time we take FRAF. And with this FRAF, whether the lining and cover can be provided, you can divide this radial forearm flap and give the lining and cover. But to give the oral competence, we have just shifted a small slender flap form here for his oral competence, because if you just add flap to that area, he may drool post-operatively. So those are the small adjustments that you need to do whenever you are taking care of the oral, lip defects. This is one lady where the primary the lip looked like the lesion like this, but then it had to be buccal mucosa had been removed so much and the lip has been shaved off. So again, and radial forearm flap was done. So we'll always replace little less, and this is how she is competent, and this is how a well settled flap is there. But whenever this defect goes more laterally, or there is a marginal mandibulectomy and RMT region, I think your third dimension starts coming in place. So this is what we need to take into consideration, the soft tissue defect that it results into. So in such cases, you require a bulky flap. Very commonly, the ALT flap is done for such defects, which you can take a thick flap, you can shape the flap, you can thin the flap. And this is the defect, and that's is pre-op and that is post-op. So you will wonder how the mouth opening is so good. Somehow this patient did not require post-op RT, that's why the mouth opening is so good. Then for the lining and cover, once you go laterally, like I said, for the third dimension, this is an chimera of the ALT flap, two paddles, separate paddles. This had a initial slight some circulation problem, but it settled down and that healed well. You can deepithelize part of the ALT. One goes for the lining and other goes to fill up all these dead pieces. So you can deepithelize and feed that in. So that gives an additional bulk. This is another ALT where you require lining, you require filler, and you require outer cover. So though initially you will feel that this is very bulky, but post-RT, these patients will, the bulk will definitely reduce. The another bulky area you can take is either you can take it from DIE pump. This is an TDAF flap, taken it from the LDE's perforator, and this is his early post-op period. When, like I said, when you don't take into consideration the soft tissue third dimension defect and put a thin pliable flap, this is what will happen. Though the area is healed and everything, aesthetically it looks like a sunken lip. So this one needs to take into consideration. If you put a graft, it will develop a trismus. If you don't take a proper flap, then there will be a sunken appearance. This is the bulk, and this is what bulk you need to add to the as the defect goes laterally. So anterior the defect or the superficial defects, I think need thin pliable flap. It could be radial, it could be ALT, whichever flap of your choice. But when the defect starts going laterally towards the angle of mandible, towards the RMT region, then there the soft tissue requirement is there. So think of it three-dimensionally, and a thick bulky flap is required. So now going to the, there are many local flaps, which Dr. Sajid Babu does a lot of flaps from the neck, but not routinely everybody is doing it. And it has a definite role. But those you need to raise it before you raise the neck before you do the neck dissections. You cannot do secondarily any patients who have done undergone a neck dissection. Now to go to the mandible. Mandible, as you can see in this, supports the dentition. It supports the tongue. It is the support for the lip, and it helps in give the definition to the lower third of the face. So any defect of the mandible will affect all these functions. His occlusion will be disturbed, his eating will be disturbed, swallowing will get disturbed. There may be a tongue fall, and aesthetically it will not look nice. And hence we need to reconstruct the mandibular defects. So the defects following resection for malignant lesions are usually with either lining or with a lining cover, or maybe along with another structure. The non-malignant cases like adenoma and adenomatoma, maybe sometimes you don't require a lining, but most of the time what cases we see usually require a lining cover with ameloblastomas also. So this could be bone mucosa or skin, or along with bone, mucosa, skin and tongue. So these are the different classifications like hemimandibular, extended hemimandibulectomy, middle third mandibulectomy, or the lateral defect, segmental mandibulectomy, or a posterior segmental mandibulectomy. These are the variety of defects that we'll encounter in getting, that is lateral turn defect with the mandible. This is floor of mouth. This is part of the ventral aspect of the tongue with mandible, and this is mandible with total glossectomy. So you need to be prepared to manage that with whatever reconstruction modality we have decided. So what do you mean by segmental mandibulectomy? It means that you have native bone available on both sides for fixation. So that it could be from one condyle to other, anywhere in between, you have the native bone available. While in posterior segment or hemimandibulectomy, the native bone is not available on one side of the defect. So it's available only on one side of the defect. Marginal mandibulectomy, usually you don't have to do any bone reconstruction because the continuity of the mandible is maintained. And usually the posterior segment mandibulectomy defects, ideally all should be replaced like with like, but in a high volume center, if there is a triage, the middle third takes the priority, and the posterior segments are usually replaced with an soft tissue flap like PMMC or an ALT. But ideally replace bone for bone, the functionality will be much better. So what are the different modalities for reconstruction mandibular defects? These are non-vascularized bone grafts, a soft tissue or reconstruction plate, or vascularized osteocutaneous flap, pedicle one and free one. In an onco setup where radiation is required, non-vascularized bone graft have no role because they do not tolerate radiation. Soft tissue and recon plate is a time-buying procedure, or patient is very high morbidity, comorbidities are there, or the expertise is not available. So you put a recon plate thinking that you may be able to do a reconstruction at secondarily at some point of time. These pedicle osteocutaneous flaps like pectoralis, trapezius, trapezius, though they are vascularized, but they have a quasi blood supply. They are not really vascularized bone grafts. Only the periosteal, some periosteal circulation is there. But nowadays you have the free osteocutaneous free flaps. Many are available like DCI, scapula, lateral border scapula, or radial forearm flap, and free fibula osteocutaneous flap. I think looking at my marking only, you'll see that that is the gold standard that is used most commonly all across the world, free fibula osteocutaneous flap. If we compare all these different vascularized bone grafts, if you see the length, quality, contouring, potential, pedicle length, vessel size, soft tissue, gonorrhea morbidity, I think fibula scores maximum. So I think you don't have to really look somewhere else. And that's why the fibula is taken, because the amount of bone available and the skin available is too much. And because of its dual blood supply, like a nutrient and the segmental periosteal blood supply, it is possible to divide it into multiple segments. Osteointegration is possible, skin is reliable, and the final aim, the dental rehabilitation, is possible. The vessels are sizable. This is a cross section where this is the fibula. It's supplied by the peroneal vessel, which is in the deep posterior compartment, and its skin is supplied by the posterolateral septum like this. You can leaving 2 centimeter anteriorly and up to midline behind, and up to 6 centimeters from lower and upper end. That much skin you can take it with one osteocutaneous fibular flap. So whenever patient is sent, we'll do the clinical evaluation for the fibula, ask for any history of trauma or any peripheral vascular disease. Usually simple palpation of dorsalis pedis and or posterior tibial artery behind the medial malleus are adequate. If they are not palpable, do an audio Doppler. If that is confusing, then ask for a color Doppler. Very rarely you will require a CT angiography to locate the vessel. Unless there is very doubt or something has happened to the leg and you're not sure, then only a CT angiography would be done. Like I said, leaving 6 centimeter down and 6 centimeter at the upper end, lower for the stability of the ankle and upper to protect the lateral common peroneal nerve. The whole this much skin paddle can be harvested with the fibula. And if the patient is tall, you'll still get a more one. So to simplify, leaving 6 centimeter at both ends, harvest the whole length of fibula if you are doing a simultaneous harvest, because you can have a two-term approach because head and neck is one and other one. Harvest required size of skin paddles. So we give anterior exploring incision, you can reduce it by a posterior location of the perforator. Along with FHL, it protects the perforators and is the ease of harvest, and it can be used as a feeler in the soft tissue deficit in the head and neck region. And we are using K-wire template for planning osteotomy or any other method, whatever is preferable with you. This is always the peroneal surface is the flat surface taken for fixation. So do that as a fixation. Plan the osteotomies from distal to proximal, taking care of the perforators. So whatever extra bone that you discard proximally gives you an additional pedicle length, because if you are doing simultaneous harvest, you don't know where you are going to get the vessels. There are different methods to get exact shape and dimensions for the jaw reconstruction, because fibula being a straight bone, there are now readily available, easily available stereotherapeutic models, pre-plating or using external fixators, or using excise specimen for shaping, or use 1:1 CT scan image, that X-ray plate for contouring your plate, or nowadays the CAD-CAM technology is used very routinely, or the K-wire template which we have developed in Tata. So stereotherapy models, prefabrication of plate, it's a mock surgery, most ideal, you give a customized mandible. But it needs CT scan, may be time consuming, costly, and plan may change if disease progresses, or the facility may not be available everywhere. Using external fixator, sometimes it is possible, but it may not be easy due to tumor growth. So like such patients. Or using excise specimen. The specimen may be fractured or distorted, or tumor growth overlaps the bone, or risk of spillage of tumor if you touch that for using the plate bending. This is X-ray template. That is like you have an 1:1 CT scan, and then you can cut that out, what the portion is going to be there, and use it as your contouring thing for shaping the mandible. That is one of the methods. And nowadays it's a CAD-CAM technology. It's a customized mandible where you will get ready-made the jigs for the cutting at the head end and for the fibula also. So you don't have to think much. But it is time consuming, but that's a customized mandible that the patient gets. And this K-wire template, which we developed at Tata, because we used to bend the K-wire template and then use it. And then one fine day we realized that it is almost coming to the same shape. So we took the mandible, took the angles and prepared a template. And that became a part of our instrument set, which was, though it's not a customized mandible, it is cosmetically and functionally an acceptable mandible. This is how you do the closing wedge osteotomy. So the wedge of the triangle is always on the medial side. These are the different osteotomies: 1 segment, 2 segment, with soleus, 3 segments, 4 segments. This is one such patient. Whenever you don't require an outside skin paddle, then you can hardly make out that reconstruction has been done because only the lining is there. This is one such patient. Whenever you can close any defect primarily, then also you can't make out that something has been done inside. This is a lateral defect where again mobilized and closed it primarily. Because the moment the skin comes out, it looks like a patch. Here the external paddle is required, you cannot close it primarily. So we used to deepithelize the tissue and bring the skin paddle out, and that's his post-op. This is how a perforator is there, and that's the diagrammatic representation of the deepithelialization. That goes for the lining, that's for the outer cover. This is one such patient again. But this sometimes we had a partial necrosis or a total necrosis of the deepithelial segment, which we had rotated out. So this will result into partial necrosis. Whether it is partial or complete, it will delay in adjuvant treatment, expose the plate, and then the whole treatment will not be completed in time. What we realized that every time we used to say the perforators, then we started dissecting those perforators and preserving those perforators. So you may get one perforator, two perforator, three. I mean, there is a variability which you can get it Doppler done and see. And then perforator origin, we used to dissect them out. You need to choose a right perforator, because one perforator for the intraoral lining is a must, because it's very difficult to shift something inside, and one perforator for the outer skin. So whichever you want to move it outside must come off bone, otherwise it does not shift, because this septum is very small. So this is dividing the skin paddle on two separate perforators. So you converted this flap into chimeras. So it can have a skin paddle bone or only skin paddle. So these are the different divided skin flaps. Like in these huge defect can be managed with single osteocutaneous free fibula flap. This is a central defect, again a divided paddle. This is we have taken along with that because there was huge tissue defect. You can take hemisoleus or part of the soleus which goes inside, and that's how it fills it up. Or it can have a tongue defect. If this patient had a tongue excision, he had a neck skin excision, he had a hole from angle to angle bone excision. So this is how the skin paddle was shaped for the tongue and for the lining, and that went for the skin cover outside. This is how the chimera was developed. And this is what is his tongue after a surgery. But sometimes the perforator location is not ideal, then you can convert that perforator flap into a separate flap and use two sets of anastomosis and give an outer cover. This is what we send patient with to the RT, and what we get back is totally different. This we call it as 2-in-1 because you are converting part of the flap as a second free flap. But sometimes the defect is so extensive intraorally and outside, then if the leg is not adequate, you may require another skin to come in. So it could be a pedicle flap like PMMC, DP or forehead, or it could be a second free flap. The choice will be whatever you want to choose. This is a double free flap, bone for lining and cover, lining, and the cover is by ALT. This is what happens with post-RT. So whenever you are doing an mandible fixation, some tips that you need to undo the neck extension, because in neck extension, the mandible drops. Do temporary IMF if teeth are present. And check that it is not prognathic or retrognathic. Check the midline with the help of maxillary teeth. And check occlusion on table. Undo your IMF fixation and check occlusion on table. It should come with one single finger. Then only the occlusion will stay post-operatively. There is no site specificity of fibula flap harvest. You may develop your own algorithm when you start doing it. Check on table that the anterior tibial vessels are good from the upper end to the lower end, as we are doing an anterior approach. If they are good till lower end, then you worry about whether it is going to be a peroneum magna, that is peroneal dependent lip hose. Do not make any segment smaller than 2 centimeters when you are doing multiple osteotomies, and it may reduce its soft tissue attachment and may become avascular. Like I said, plan from distal to proximal, taking care of the perforators. And to shift the skin paddle, the perforator must come off the bone. Otherwise, it doesn't shift, it stays tethered over there. And soleus can be harvested with it for providing bulk. This is what I said, the site specificity is not there. If you take left side vessels, left side fibula and take right side vessel, the skin drapes from intraorally. And if you take left side fibula and use left side vessel, the skin drapes from below upwards. And that's the thing how it drapes. There are certain new developments now, like Ronner's technique. It is a prefabricated fibula. You put, you have the CAD/CAM technology. You put the implants in the leg. You put the graft. You bury it, and after 6 weeks, you harvest that, shape it like a bone, and fix it. Patient wakes up with a denture in the mouth. And the other concept that is popularized by Max Fax people only, but I heard it from Fu Chanui, a jaw in a day. That patient again wakes up with an denture in the mouth, but taking care of that skin paddle thickness, the denture is applied. That's not functional, but afterwards that is removed and given a functional denture. And nowadays you are hearing about the tissue engineering mandible, about with the stem cells and growth factors. These are the new things. Maybe one fine day you will get a flap across the counter, I want this, and you just come and put it. This is the sort of algorithm that we have developed at TMH. When to do what defects can be closed from primarily, what the different cases that I have shown you. The ultimate aim in this is rehabilitation, dental rehabilitation. So sometimes the patient are willing for primary dental implant, or sometimes they want to get it done secondarily. But many a times the secondary reconstructions, dental implant, very few of them are willing to go because they have, by that time with the radiation or chemo radiation, they are really don't want to undergo any more surgery. So overall dental rehabilitation and an onco patients are maybe about 10 to 15% all across, if I'm not mistaken. Thank you.
Thank you, madam. That was an excellent presentation of what is required. And it was very nice to hear you go from one small defect to the large defect. So I think many of the delegates will have so much of doubts to clear. Please stay till the end, ma'am.
Yes, I will. It
will be at the end.
Yeah, because I'm interested in hearing the other talks, because next is the CAD/CAM technology, I think.
Thank you. Yeah. So next, we'll move to the next presentation. For this, I would invite Dr. Vidyadharan to moderate. Dr. Vidya has done his MCH in head and neck surgery from Amrita Institute and is currently working at Apollo Proton Center in Chennai. He's interested, he's a trained person in microvascular surgery. He has interest in diglotology as well, and the surgery is related to that. Over to Dr. Vidya for the next presentations.
Thank you, Professor Sajid. It's a great privilege to introduce the next speaker, who's Professor Carl Peter Cornelius, who's a consultant in Department of Oral and Maxillofacial Surgery at the Ludwig Maximilian University in Munich, Germany. He did his medical education at the University of Friedberg, Düsseldorf, Tübingen, and his training in OMFS in Tübingen University under Professor N. Schwenzer. He has been affiliated with the departments of oromaxillofacial surgery at various institutes, including the Basel University in Switzerland and the German Armed Force Military Hospital. And he has numerous publications in various international journals, and his special interests include maxillofacial and orbital trauma and reconstruction, and nerve lesions and repair of cleft lip, palate, and palate surgeries. He will be talking about the role of 3D planning and plate contouring in head and neck reconstruction. Professor, please go ahead with your talk. Thank you.
Thank you for the nice introduction. Well, I'm afraid that I will give some redundancy in this talk because Dr. Yadav has just referred to many aspects of reconstruction plates and reconstruction of the mandible. Nonetheless, I'll try my best. Okay. I hope you can see me and my screen now.
Yes.
Okay. I somewhat changed the title because you were talking about plate contouring, and I don't think that you are interested in plate bending. So I changed that to patient-specific toolkits, which consist of STL, stereolithography models, cutting and drill guides, and metal implants in head and neck reconstruction. So all this starts with 3D virtual planning. And from this 3D virtual planning, we get the models or the templates. And for assisted surgery, this is also called computer assisted surgery. And finally, we get patient-specific implants, or PSIs, as we say. To brief that up, we can refer to CAD/CAM surgery. So CAD stands for computer-aided design, and from that, computer-aided manufacturing of patient-specific implants is done. Here we have 3D printing technologies involved, and there are four kinds of printings that we can use. The primary type is the contour model. The contour model represents patient-specific anatomy that is three-dimensionally printed and used as a replica of the patient's bony anatomy for contouring hardware such as titanium plates. And that, of course, abbreviates and shortens intraoperative timing, because all the structures are known already and we know the resection defect beforehand. Then the second types are guides. Guides use the negative space surrounding a patient's bony anatomy to print patient-specific templates, so drill guides, and as you can see here, cutting guides that fit only on a certain segment of bone intraoperatively, and these guide precise drilling and also precise cutting. Then the third type are splints or interocclusal wafers to reestablish the occlusion, and they are completely planned because they are not existent in normal anatomy. So they give the post-operative position of the patient structures, and the most typical example is occlusal adjustment. And lastly, we have the implants. The implants are defined as three-dimensional printed objects directly implanted into the patient and used as a three-dimensional object. So the workflow of this is the medical imaging, and then we go for manipulation of this imaging to produce digital files, so 3D objects, and that is then transferred into printing software. And the 3D printing of the 3D object follows, and finally this can be modified by post manufacturing. So again, the workflow, you can see it here: medical imaging. The DICOM data are imported, then the segmentation takes place. After that, there's virtual surgery and the slicing, and finally the 3D printing of whatever you want to have, one of these different categories of objects. This is also called rapid prototyping technique, and this comes in two varieties: as a subtractive form or in an additive way. So the subtractive form is very well known since centuries. Wood carving is something like that. So you just take away some substance to get the form and shape and dimension you want. And additive stereolithography is more modern. There are several techniques used for that prototyping. For example, fused filament fabrication and fused depositioning modeling is the same, and the filaments go into the machine, and then the objects you want to have is built up either by plastic filaments or even by metal filaments. Another technique which is more modern is the so-called laser sinting, selective laser sintering, or selective laser melting, or electron beam melting. This can be done with plastic or with metal spheres. The metal spheres are melted and sintered, and they can go together just by their surfaces. They melt together by their surfaces, or EBM can make even more and melt the whole particles into one new object. Okay, another old technique is CNC modeling, numerical controlled computer modeling in metal machines, and these are subtractive techniques again. This were the first patient-specific milled reconstruction plates that were available. In reconstructive work, the applications go from post-traumatic deformities, congenital deformities, over orthogenetic surgery into tumor ablation and head and neck defects. And that's our topic today. I brought you a lot of slides, and I probably will not be able to refer to all of them. So I just try to refer to mandible reconstruction here. Mandible reconstruction has several options. We have heard about that just before in the talk before, and reconstruction are one of them. Reconstruction plates usually go together with bone flaps of any kind. Okay, so reconstruction plates come in various forms and shapes and varieties. Here's one of them. And from Synthes and the AO, over the years, many different types were propagated, and they finally ended up with so-called preform plates. The preform plates have the additional benefit of being more stable than other plates because they have a middle segment that is unchangeable. And this is calculated on average mandibular sizes, and only the back end and the anterior end are, as you can see here on the lower right side, are bandable. And there's a choice between different sizes for the middle part, for the red part, which is more stable. As you can see, it has no between the holes, it has no incisions and no gaps there. Okay, so this is how it is done. That is a pre-plating technique. First, the plate is applied and screwed to the bone, and then the defect is created, and the defect may be filled with various materials. The indications for such mandibular reconstruction plates are osteosynthesis after excess osteotomies. They may also be used as protection or reinforcement of bone after rim resections, and they can stand alone for bridging segmental defects, but that's not a good technique. I will refer to that later. And usually they are used together with free bone flap reconstructions to stabilize them. They have to obey the bridging principle, load bearing. The bone segments are stabilized, and they need to absorb the full functional loading in order to prevent displacement. Here again, the segmental resection with vestibular pre-plating. If the tumor is not growing exophyseous, with bulging the outer border or the inner border of the mandible, then the implant can just be put on that, screwed to it, then it is removed, the resection is done, and the plate is reinstalled again. And finally, the bone flap can come to that. Just to see that in a little scheme, if the inner and outer cortex is intact, we can use this vestibular pre-plating mode. If the outer cortex is bulged by the tumor, by the shear tumor size, then you can use a basal or lingual pre-plating technique. And if the outer and inner cortex, you can use double plating or positioning plates, or even STL models or virtual planning or patient-specific implants. Just the basal lingual pre-plating that can be done with such plates, that helps a lot and is very easy. The double plating goes in this way. A plate is done over the occlusion, behind the occlusion, and then the resection is done. The plate is bent in situ, and the defect is then created. And this is a clinical example, it looks like that. This plate there could not be removed. As you can see in the anterior portion of the mandible, this was a recurrence of a tumor. And then we just did a double plating in this way to pre-plate, and then the resection was done. The final reconstruction plate was installed, and then a fibular graft was put in there, as you have seen just in the talk before. Stereolithography models can also help in plate contouring in such tumors. This was a sarcoma, and we did an STL model category 1. This was then sliced down, and here you can see the double check of the plate with a part of the STL model. So how did 3D virtual planning begin? How did the journey begin? Once upon a time, we had tumors like that, a typical ameloblastoma, multicystic, as you can see. And then we made these models, and we made prosthetic work. And on the basis of this, a new mandible was created, which is in the lower right. And on that, we created an acrylic inferior denture for the mandibular denture. And with that, we went into the planning. We looked for all the angles. That is just like the key wire, but here it's done with wooden blocks, or with wooden I don't know the name, with wooden things. And this is then transferred into the shape of an STL model of the mandibula. You can see the wedges that have to be taken out to do closed osteotomies. And on the basis of that, the plate is bent. This has a very simple geometric form. More complicated geometric forms may be done. Here, the resection of the tumor together with the joint, and then the whole thing intraoperatively. The dentures are wired by MMF screws to the upper dentition, and then the plate is introduced, and the fibula is cut, as you can see here, according to these pieces which were pre-designed. And this was then, the plate was then equipped with the fibula and a soft tissue pedal, and that was inserted then into the mandible. And the joint on the right side of the patient was not replaced. It was just a free-ending fibula end that was sutured to the intra-articular disc. Here, the final result then. And well, so the template assisted surgery, as you've seen, that was our previous practice. And it all started with data acquisition by CTs or CBCT scanning and imaging. Then dental casts were necessary, interocclusal wafers were necessary, as well as dentures. STL models of the mandible and bone flap were necessary. And then we had to do a lot of manual and dental lab planning. The osteotomies, the segmentation, as you have seen, the plate bending. And finally, we were looking for transfer vehicles, and the transfer vehicle of those days were the pre-bent reconstruction plates and some cutting guides, if possible. So this all changed with computer-aided design and computer-aided surgery. It became possible I learned this in Basel by Leigener. He designed this as one of the first. This was a breakout picture of that. And with that, the fibula could be put into pieces and put into the defect virtually. And we had also then these cutting guides. Dennis Rona was also in Basel. He was just mentioned, and he designed this to put implants at the same time in a prefabricated way with the fibula. But this was that was all done also in the previous style in the dental lab by Peter Bucher, who was one of the dental technicians in those days. Okay, so the updated and current practice was based on the Leigener scheme with data acquisition, and then all changed. Virtual planning platform was there for simulation of wedge osteotomies, of the segmentation for the neomandibular segments, the insetting of the plate, and the template design. And then this was followed by rapid prototyping with reconstruction plates produced by CNC milling or by electron beam melting. So either by a subtractive technique or by an additive technique. And the transfer was then very easy. The STL outcome model and the cutting guides were used to transfer the whole thing into surgery. The resection was done, the contouring of the bone flap was done, and then the customized recon plate in form of a patient-specific implant was installed. The mandibular reconstruction can go into in various geometries. We have just seen the very simple one replacing the left and right body of the mandible and the anterior part in a simple form, as you can see on the upper left. And this can be modified into much more gentle forms, but this is due to, of course, to more osteotomies and more segmentation, which may make the whole thing less reliable, especially if the vascularization is compromised. Okay, then the reconstruction plates were also done, as I've mentioned already, in a rapid prototyping style, as you can see here. This was one of the first papers on that. So this was the missing link between the planning and the transfer into the surgery. And the PSMP, so the patient-specific mandibular plating, had some special features. The mandibular resection guides and the fibular cutting guides were equipped with drill holes for screw placement. Otherwise, it would not have been possible to put in the plate just without any MMF or without pre-plating or without anything else. You just could do the resection and then put in the plate and put in the fibula. So this was all tried out in cadaver studies we did in Austria, as you can see here. The plate, that was the planning of all the segments of the fibula, multiple segments, just from ear to ear almost. And then the PSMP, the plate, was designed according to that, with knowing all the screw lengths and the screw placement beforehand, before the surgery. This was then transferred by a drill and cutting guide for the fibula into the place and the cutting guide for the mandible. So this was mock surgery, simulation, and that was then transferred. Here you can see it, the resection. First the cutting guides and drilling guides are sutured to the, or screwed to the bone, and then they are used for cutting the bone for the osteotomies and also for the placement of the screw holes. There are various techniques for the osteotomies. There can be slots or there can be flanges. Here we have slots to cut them, and that is the same thing for the fibula. The fibula can be either contoured and wedge osteotomized in place, while the vascularization and the vascular pedicle is still intact, or on the side table, as you can see here. Both is possible. Then for double checking, the plate is screwed in, and with all these parts made out of plastic, you can use the right sitting. and you can use if it will fit in the end. And then the whole thing is put together on the table again and then installed. And these PSMRPs give you a high accuracy, even in multi-segmentation, and they also allow for the placement of dental implants primarily. That is the concept of jaw in a day that was initialized by Levin. Okay, so just an example, patient-specific plate. This was a secondary reconstruction. One of the typical problems you have with plates, if there is no bone reconstruction, then they may be exposed like that. And of course, this plate has to be removed and the defect has to be filled with some bone flap. So this was the planning readjustment of the segments, further resection of the segments because they started to sequestrate, and then the reconstruction already with the placement of implants, just to get some idea, then the vascularization, the peroneal vessels, and the fibula and the different segments. And of course, there has to be some distance to the fibula, to the tibiofibular joint. This has to be preserved. And here you can see how it is planned. First, there is some outline of this plate and all these segments are shown. And then the plate is done according to the planning. You know the size and the length of every screw beforehand. You do not have to think about it anymore or to try it. And this is how the whole thing comes then into the operating theater with all the cutting guides and with the plate and also with the template for the fibula. The plate is installed and the fibula is cut with all the wedges and the skin pedal. And that can also be double checked and tried in the SCL model of the defect of the mandible. And that is then installed and revascularized by the microvascular anastomosis, re-anastomosis, and that was then the end of surgery. And a few days later, we did for control a CT scan, and that is how it looked post-operatively. Multi-segmentation may also go in another way. This is often called the double barrel technique. That is nonsense because double barrel go side by side and not over and under barrels. We call this double decker and over and under barrel, which is more appropriate. And here you have to look how to place the peroneal vessels, and you have to look how to arrange that to get the vascular pedicle at the right end. And here you see one of these examples. I'm not going to go into this and showing to you another case, but just the equipment you get into the operating theater then with 2 reconstruction plates. And again, this is all meant for double checking, and the turnover or flip over needs, of course, a resection of the mandible of the fibula in between to be able to bend it over. Just a case of that sorry, it's not a tumor, but it's a gunshot injury which came from Libya. Here you see the comminution of the mandible, and this was badly treated. All these segments were sequestrating because that was not a load-bearing osteosynthesis. And this all had to be taken out. Here you see the debridement of the segments or the fragments, and then we've put on an external fixator like that and just kept waiting with all the segments that could be left to see if they were surviving or if the vascularization was not adequate. And that is then the defect and the patient. And well, then all these segments were put virtually into their original place, or fragments were put into their original place, as you can see here, and the rest was then, the defect was then filled with an over and under barrel type of fibular graft. And in this patient, we already planned prematurely or provisionally the implants, where they should go. This is done by virtual insertion of teeth. And here you can see this insertion into the bony segments of the over and under barrel fibular construct. So this is all done virtually. And also the occlusion is checked virtually if it really works. So the upper part is the existing part, the lower part is all virtual, non-existing in the patient anymore. And here you see the transparency of the implants and the mandible. And here again, the location of the future implants. And here also the location of the possible future implants. And this was in the days when we still used conventional reconstruction plates, and they had to be bent preoperatively. And for that, we used the STL models, as you can see here. Today, this would look a little bit different, intraoperatively double checking again of the size of the defect with all the platings that could be used later on, then the fibula with the fibular graft and the cutting of the fibula with a piezo element, which is much safer than using a saw. I don't like it very much because for me it's too slow. I prefer cutting the bone with a saw because that is much faster. Okay, and then the insertion of the fibular bone pieces into the defect and the revascularization, and then patient again, a post-operative panoramic view and a CT view of all that, and then the insertion of the implants that can also be done in a planned fashion on a virtual basis. For this, you have drilling guides for the implants that are also created virtually. You can see them on the upper right side. And here the planning, of course, we introduce much more than initially planned and initially done on the planning. And it's necessary in the fibular grafts to put in the implants bicortically, otherwise you will lose them. It's necessary for their stability. Here you see all the axes of the implants and the implants shown here, also in the upper jaw. And that is then done with this template here. The implants are put in by the help of a template to locate them in the mandible here in the right place. Here you see the implants in the upper jaw and in the lower jaw. And well, unfortunately, I don't have a picture of the implants and the prosthetic work. Well, another problem which we deal with in head and neck tumor surgery is osteoradionecrosis of the jaws. Here you have, well, quite an obvious example of that. And this has to be removed. This, in my opinion, osteoradionecrosis is one of the worst diseases you can have at all. And it's really hard to treat, and fibula may be a solution, but it's not a reliable solution all the time. Nonetheless, we have no other means than doing this. So in this case, we used also a fibular graft from angle to angle, the planning again, and the exciting point of the pedicle. And here we used a EBM plate, so an additive plate that is not computer milled or CNC milled. This is done by laser melting, as you can see here. And this allows for much more shapes and much more flexible designs than the CNCs, because the CNCs can only go into some axis of the milling machine. Here you have all the options. You can even combine small holes with big holes in the plate, and additional bars and interbar sections, and whatever you like that is possible, and whatever seems appropriate. So here again, the planning, and then the toolkit that comes into the operating room. It's easily identified. There's one on the upper end that is needed to shape the edges between the anterior segment of the mandible and the bodily segments. Here it is again, and it's just used to cut down the bone there to make the plate really fitting. And that is then the osteoradionecrosis. We removed the bone, we resected it by use of the templates there. Then the plate was introduced and double checked, as you can see here, with the STL model of the fibular segment, so the hybrid fibula, as we call it, then the resection of the anterior edges to be able to place the fibula finally into the defect. And here we have the post-operative conventional radiograph, the panoramic X-ray. So the critical appraisal of the patient-specific mandibular reconstruction plates, it refers to the double checking method, and that is really precise. By this we can reach an increased accuracy. And this is, of course, a necessary prerequisite for the placement of an osseous dental implants, especially if you want to do that in the same surgical step. On the other hand, we have increased rigidity in long-spanning defects. The screw holes can be angulated in areas where they are not accessible due to the soft tissue coverage, for example, in the area of the condylar processes, and it allows for an adequate vertical leveling of bone flaps. Nonetheless, if anything goes wrong, it's an unforgiving technique. And so far, PSMRPs cannot combine with condylar replacement items because they need a fossa, and a fossa is not provided by the technicians so far, by the technology so far. A limitation of the fibulas is the fibular length, especially if you want to go for this over and under barrel techniques, as you can see here. So what are the options? One of the options may be that only a partial part of the mandible is augmented, or the fibula is put on a level not on the base, but in the middle of the mandible, as you can see on the right side, or you can use the fibula together with bone carriers, as you see here. These bone carriers are a kind of mesh, and this mesh may be filled with bone, and the fibula can go below it or on it. Here, a closed one of these cages, and I'll show you a case with a fibula. This was a secondary case again. There you have the time for planning, of course. In primary cases, well, it depends on the size of the defect that we do it. We don't do it in every defect. We still do it freehand, just as Dr. Yadav has shown beforehand. Okay, so in this case, you would also need the integration of dental costs into the whole planning. And here we saw that it might be necessary to do a sagittal split osteotomy on the right side of the mandibular fragment to be able to put the condyles back into the condylar fossae. Here you see this, the bone stumps were cut, and then the fibula was put in. Here we have then interocclusal wafers or splints to readjust the occlusion. Beforehand, we had a crossbite, a lateral crossbite. Now we have the right occlusion, and that is secured intraoperatively by the wafers. And then the fibula went up in the double-decker position, so in the upper position, and the lower position was then maintained and filled by such a cage. Here again, the planning together with the sagittal split on the right side, or in fact, it was an inverted L osteotomy planned. Here you see it from all sides. And then again from the lower side, from the anterior part again, and from the lateral side, the inverted L osteotomy, also with platings that could have been used beforehand, and a cutting guide, this time made out of titanium. Then the fibula flap design again with the long pedicle. The more distally the segments are designed, the longer the pedicle, as you can see here. And then the fibula, the cutting guides in place and planned. The upper row is for the plate, and the fibula in the lower row is for the cage container. Here you see this again, and all the screws are predetermined again. And that is all you need then. That goes into surgery. Here you have all the details on all the parts. And then again, for double checking, you have all the STL elements. And this was the old plate then, already opened. The neck is opened. The vessels are already identified, the recipient vessels, and everything is built in with double checking. And the fibula is grafted, and the fibula is cut then. And finally, all things are in place, and the lower part is then filled with the remnants of the fibula. The fibula is milled down into particles, and these particles then fill the spacer there. And this is finally the post-operative panoramic X-ray. And this was also then equipped with dental implants. A couple of months later, we feel that this is much safer and allows for much more accuracy and precision. And here you see the same thing. Unfortunately, I don't have the prosthetic work. So the role of 3D planning and CAD/CAM toolkits is mainly governed by PROS, because it considers and can preserve the anatomic structures like nerves, like existing implants, and it can take care for additional osteotomies. The individual implant design allows for many shapes and many dimensions. It can be thick, it can be varied in its cross-section, in height as well as in width. It may be used with condylar add-ons, and of course it matches with, or can be made matching with, the transplant. The screw position, angulation, and screw size can be varied according to the needs. The diameter can be varied. The electron beam melted plates may be created with a specialized metal surface that allows for soft tissue ingrowth. During surgery, there is no need for MMF or pre-plating. No bending increases the stability, and of course it's in a time-saving surgery, because wedging osteotomies freehand take a lot of time, and if you have many segments, you will refrain from doing that freehand. And of course, the design versatility goes along with high accuracy. On the contrary side are time-consuming planning. What you save in surgery, you have to invest in the pre-operative planning. And the costs are prohibitively high. It requires sophisticated technical equipment, such as, for example, the special cutting equipment by piezo. And if there are any misconceptions in the whole thing, the plates will not fit, the whole thing will not fit, and then what to do then? In these cases, you deal with an unforgiving situation that really requires and challenges your skills then. Jaw in a day, we have that already. In total maxillofacial reconstruction, these cutting guides will contain in surplus to the cutting wedges, will require drill holes for the implants. And here you see a series, unfortunately not mine. Here you see the same thing, the planned implant and fibula. On the left upper side, you see the virtual planning, and that is then transferred into surgery. Here, the fibula is still in contact by its vascular pedicle, so the ischemia time is very much reduced. The plate is already put in. That is then double-checked in the STL model, as you can see on the right side. And finally, the immediate post-operative result with the lower denture in place. Of course, there are many other ways and many other bone flaps, such as the DCIA. This can also be planned in a very conservative way. It must not contain the iliac crest. It can be done from a medial approach and in a kind of a window that is cut into the bone, so the iliac crest is reserved, and that is much less invasive than the conventional DCIA graft. A variety that comes from our institution are lateral scapular border implants and transplants. Here you can see how the device is and the transplant is virtually planned for an anterior mandibular defect. Just follow these pictures. That is all done virtually, and the part that is needed from the lateral scapular border can be evaluated in this fashion. So here the new anterior neomandibular segment is just created, as you can see, by varying and by moving, rotating the scapula. That is done in the virtual world. And finally, these things have to consider, these segments have to consider the vascularization of the lateral border. And we designed a special two-piece cutting guide to be able to preserve the vascularization in that way. Here you see the angular branch and the latissimus dorsi, and also the subscapular artery on the upper left, the subscapular axis, and the circumflex scapular vessels going to the implant, and that to the transplant, and that is then cut by using a second part of the cutting guide, and that is cut then in that way and finally introduced again in the mandible. And here is the final result then, and also a CT scan of the final result. The latissimus dorsi was used to fill in the cervical region, as you can see here, and later the plate was removed then, and here you see that. And since the scapula is very thin, you have to augment it before the insertion of an osseous implants. And finally, here you have the panoramic X-ray, and then the dental planning again, and here the final prosthodontic work on that patient. Well, I think I'll close here. I would have to say a lot more, especially on the maxilla reconstruction, the use of condylar prosthesis, and so on and so on. But I think, and I'm convinced that this is only a temporary technique which we are using at the moment. And there's also already in the pipeline are navigation techniques that are combined with robotic technologies. So in the future, all the wedges will be cut by a robot, as you can see here. You see the saw on the lower right side, and this has been used experimentally as well as in first clinical work. Okay, so we will finally end here, and thank you very much for your kind attention at that point.
Thank you, Professor Cornelius. You don't have to worry about redundancy. It was such a great, wonderful, comprehensive technical talk. And it was interesting to know about the history of 3D modeling, template-assisted surgery, and computer-assisted surgery. I especially was very impressed by the double-decker technique and over and under technique, and also the anterior edge resection, how you do it. But we will have a few more, we'll have the discussions later at the end of all talks. I would love to introduce our next moderator. We would go to the next moderator, who is Dr. Adarsh. Dr. Adarsh Anand is a head and neck surgeon. Sorry. Dr. Adarsh Anand is a consultant head and neck surgeon and the head of department at the Department of the Head and Neck and Facial Reconstructive Surgery at the Head and Neck Institute at St. Gregorius Multispecialty Hospital and International Cancer Center at Tiruvalla, Kerala. He's also a visiting consultant, a surgical oncologist at the BPS Lakeshore Hospital in Cochin. He is MCH certified head and neck oncologist with special interest in reconstructive microsurgery and skull-based surgery. Dr. Adarsh, the podium.
Thank you, Dr. Vidyadharan, for that kind introduction. So I have the privilege to introduce the next speaker, Dr. Dushyant Mandlik. He's a consultant, head and neck surgical oncologist, as well as special interest in robotic and reconstructive services. He is a member of the ASCA Oncology Associates, and he works in HCG Cancer Center. And he did his MS surgery from Ahmedabad, followed by additional fellowships, the UICC fellowship, as well as the Global Oncology Fellowship from IFNOS. So he had his specialty trainings from Amrita Institute of Medical Sciences, Kochi, as well as from the prestigious Institute of Head and Neck and Thyroid Cancers at Mount Sinai Hospital, New York. He also holds a lot of positions. He's a program director, fellowships at Asta Oncology Associates, as well as the executive committee member of our national organization, FHNO, as well as he is the member and secretary of FHNO institutional fellowships. So he has special interest in microvascular free flap reconstruction, as well as robotic head and neck surgery. And his topic of presentation today is postoperative care and complications in head and neck reconstruction. We welcome you, sir. The screen is yours.
Thank you, Adarsh. Am I audible to all?
Yes, sir. We can hear you.
Yeah, thank you, Adarsh. There was an elaborate introduction. I do not deserve that much, but thank you anyway. As I have seen all the presentations, it is slowly going towards the higher and higher, and the last presentation by Dr. Karl was at the crescendo, the highest form of the technology which we can have in head and neck reconstruction. Against all those presentations, my presentation is going to be kind of a very basic kind of a presentation, where I will be taking care of postoperative care and complications in head and neck reconstruction. I will restrict myself most to the free flaps, and I will restrict myself to the complications which happen immediately post-op, because otherwise you can, go on and on and on for the complications. So this is the place from where I come, Gujarat. As you all know, Ahmedabad is one of the big cities in Gujarat, where now we have all the heritage like Sabarmati Ashram and new technologies like the biggest stadium of the world, and Namo, as you all know, it hails from Gujarat. And this is my team. I work at HCG Cancer Center in Ahmedabad, and this is my surgical team. I'm a small part of the team, and I'm thankful to all of them to help and sharing my work and knowledge. So, whenever a flap failure or complication happens, it is really difficult for a surgeon. It is difficult for the patient also. It is definitely a big traumatic experience, and it calls for a self-appraisal. Every time a flap fails, you sit down and think that why it has happened. Not only it leaves scars on the patient, it also shatters your confidence also that what happened wrong. Suddenly everything was going fine, and then one and two and three flaps failed, and you get disappointed also. And definitely, like this Hagar the horrible, you try and say that why me, and then after some thinking, the God says that why not? You have done something wrong. So always the flap failure and complications are the learning tool for us. When we think about the flaps and flap failures or complication, it doesn't happen just in one phase. For any successful reconstruction, three aspects are required. That is, one, planning, which happens in preoperative phase. Second is execution, which happens in intraoperative phase. And third is the care, which happens in postoperative care. Surgery begins first in mind, then it is executed on the table, and then you have to nurture and tender it like a kid in the postoperative phase. Similarly, if you fail to plan, or if you fail to execute, or if you fail to take a postoperative care, then you fail, your flap fails, your reconstruction fails. Today, we are going to talk about the third part, that is postoperative care. Now, what are the aims of our postoperative care? We want our flap to not to fail, heal better in a proper way, and we want all the complication to be avoided, not only postoperatively but delayed complications also. And there are two broad parts of postoperative care. One is the general care, and the second is flap specific care. Now, whenever your patient undergoes a flap surgery, usually it's a long surgery, around 6, 7, 8 hours of the surgery. And most of the patients are in mid-age or in a late age. So medical stability of the patient intraoperatively and immediate postoperatively is of utmost importance. The patient's blood pressure, patient's vital, and the DVT prophylaxis takes a very good importance in that. A patient who is hypovolemic or has blood pressure problems, hypo albuminic, or having the low pressure, can have decreased perfusion in your flap and cause multiple problems. A good pain management is required perioperatively. As we know that pain stimulus can induce many systemic changes. It can cause fluctuation in your pressure, it can cause vasoconstrictions, and it can cause problems in the flap. As well as due to pain, the patient usually moves the neck and can cause certain postoperative problems, and you cannot ask them to hold the posture. So a good pain management is also required postoperatively. Your patient needs to have a good perfusion for your flap to perfuse. It should not be hyperperfusion, or it should not be hypovolemia also. The patient's temperature needs to be maintained adequately. Most of the times, if you see in ICUs, they are very chilled. So you have to take care that your patient is not chilled. You have to maintain the pressure with warm blankets. You have to also see that you don't use those hot fans which can actually burn or tear your patient. because the sensations are not there in the postoperative time period. As you know, a violent movement of the neck or sudden movement of the neck or certain postures can cause pressure or kink over your microvascular anastomosis or can twist your pedicle or vessels. So you need to maintain a good posture. Mobilization is also required. As I have previously said, that DVT is one of the problems which can happen with your flap. You need to mobilize your patients at the right time without causing compromise to the posture. Now, there are certain flap related parameters which you need to monitor, because if you recognize those parameters early, then you can avoid the complications. And flap monitoring is utmost important in that area. Now, as I have said, I will stick mostly to the microvascular free flaps in this presentation, but nonetheless, this or the part of this talk also is true for other flaps also. Usually our patients who undergo microvascular reconstructions end up in a special care or a hyperdependency unit or in an intensive care unit. Till date, clinical examination has remained gold standard, and it has to be done by somebody who has a knack of seeing the flaps, who has seen flaps and know how to interpret them. So it has to be an experienced staff or a doctor. There is a big variety in which frequency you should observe your flap, but in general, for first 24 hours, you want your flap to be monitored nicely, because it is first 24 hours where most of the anastomotic failures happen. So in first 24 hours, you examine it in half an hourly or 1 hourly clinically. The time period increases after that. In next 24 hours, you can go for a 2 hourly or 1 hourly examination. And then after, till the patient is with you, say around 4 or 5 days, it can be 4 hours after that. What you need to see. So you need to see the color of the flap. You need to see and examine the temperature of the flap. Many times there are bipedal flaps on the outside of the head and neck area. So you can see the temperature also. Sometimes what happens that your flap seems cold because of the sympathetic denervation, but you have to interpret it in that manner. Turgor is one of the good aspects which you need to see, and the capillary return of the blood. This all parameters are they should be normalized, or they should be compared in the position where you have seen it immediately post-operatively, intraoperatively or post-operatively, and those parameters or that picture is compared later on with your flap. You need to monitor your flap with a scratch or prick test, especially in initial 24 hours or 48 hours. Then after, you can decrease your scratch or prick test. Charting of the flap parameters is very important. You need to chart all the aspects like color, temperature, turgor, capillary return on the frequency basis, and you also need to put down the sign who has actually examined the flap, so you can kind of talk to them if you find something abnormal, and you can have a double look also. Photography is one of the important thing. I think nowadays we have WhatsApp, we have many sharing medias, so you can use this photography for the same records. You need to be very sure that what happens is sometimes with an extra flash or under flash, your flap may look different. So don't judge your flap on the photograph, but just use it as an ancillary thing. You need to see about some compressive dressings around the flap. Sometimes what happens that your tracheostoma is done, and the tie of the tracheostoma is over your vessels or over your internal jugular vein, compressing it. So you need to avoid pressures or compressive dressing on and around your flap, and you need to allow it to breathe and drain properly. You need to keep your flap and drains in the vision. Don't entirely bury your flap on a big dressing so you cannot visualize it. You need to keep drains out so you can see the drains. If there is some hematoma happening or some bleeding is happening, then you can immediately act and do the needful. Clinical examination has definitely remained gold standard, but sometimes you need some external help also. And for that matter, you can have a Doppler. It can be an invasive Doppler or an external Doppler also. When you are using an external Doppler, whenever you have inserted the flap, you need to know where your vessels are so you can guide your sonologist if you want to actually trace your vessels and know how the vessels are working. Sometimes there are buried flaps, and there are advocates of the buried flap monitoring also. I myself have used Cook Doppler in some of the cases, but I found it and by that sword that few of my flaps died because of the constriction or kinking of the vessels laterally to my monitoring flange. So most of the times in head and neck, you don't need a buried flap monitoring because the flap is usually visible. Many a times, even the flap is thin, like in buccal mucosa or so, you can even palpate your vessels. So buried flap monitoring is not very much required. Certain flaps like jejunum, you can have a monitoring segment outside, which can give you an immediate sign of some problems. And there are certain newer devices like uh, Doppler devices, laser Dopplers, temperature meters, and perfusion monitoring devices, perfusion scans available, which can help in certain difficult times in flap monitoring. Now you have to see that your monitoring is adequate and what are the problems which can happen in the monitoring. One is inexperienced staff. As I previously said, that you need to really know your flap and you need to really know how to interpret the signs of the flap. So the staff as well as the doctor has to be somebody who knows how to interpret it. There are certain buried flap. When the flaps are not visible, the monitoring is really difficult or an issue. As I have said, sometimes in an invasive Doppler, the probe or the sleeve slips or compresses the vessel or kinks the vessel. At that time, there is a false alarm or there is some problem which happens with the perfusion. As I have said that when you want your radiologist to trace the vessels, you need to be with the radiologist on the bed because you know where you have placed your vessels. Otherwise, the radiologist will do the Doppler of wrong vessels and will give you a wrong interpretation. So, Dopplering of wrong vessels is also a problem. Tight closure, hematoma, and compressive dressing sometimes doesn't allow you to see the flap. Hematoma actually gives you a wrong picture sometimes, and that can cause a monitoring issue. Now, as I have said that you compare all your post-operative examination of the flap with a normal flap, and the best time to establish this normal flap is immediately intraoperatively. Once your flap surgery is concluded, your flap is perfusing nicely and normal. So you see that how much warm the flap is, what is the color of the flap, what is the normal turgor of the flap. And this is the time where you see that on the scratch at what time the blood is coming, because you all must have observed that even though the scratch test is the gold standard, but the coming of the blood or the rushing of the blood or the color of the blood differs with different flaps because of the dermal thickness and all other different parameters. So you need to compare your flap with the normal of your own flap. Now, the immediate thing which happens to a flap or immediate thing which you are worried about your flap is the vascular compromises, which usually happens in the first 20 to 24 hours. And for that only, we actually monitor the flap very intensely during the first 12 to 24 hours. So most of the time it happens that it is due to some anastomotic failure or some technical failure doing in the anastomosis. The vascular compromise actually starts immediately intraoperatively, and you are not able to judge it, and it shows the early signs in your postoperative period. So be very vigilant when you are 100% sure that your flap is fine, your vessels and your anastomosis is 100% good. Give some time to your flap inside your OT only and judge it at that time only, because you don't want to take your flap inside back. So you have to be practical about your judgment, be very critical about your judgment, don't show mercy in that, and be 100% sure on the table, so you don't have to come at mid of night to explore the flap. As I have said that capillary return, scratch test or Doppler of the vessels is also very much important when you are going to monitor the vascular compromise. You need to understand and know that what is the time of scratch and what is the delay of the scratch, what is the color coming, and the person needs to be really experienced in monitoring it. Whenever you are in doubt, rushing to the theater in the golden hours has never become a problem. If you are in doubt, and if you are actually seeking out others' help, or if you are actually seeking out other investigation to confirm your doubt, usually it is the flap or it is the anastomosis which is at the problem. So there is no harm in taking the patient to the theater in the golden hours and try to salvage your flap, which will give a good result. As you see here, there are few examples of vascular compromises, and there are few reasons behind that also. In the first picture, you can see that there is an partial venous occlusion. Here you can see an arterial problem where the flap is pale. Here you can see an early venous problem, and here you can see an advanced venous problem. So all of them have different anatomy, different flaps, and different signs and symptoms, and different scratch test results by clinical examination. And you can definitely diagnose what is the problem. A pale flap is usually there when there is an arterial thrombosis, or if there is an hypotension, which is actually hypotension, hypovolemia, or vasospasm, which is leading to hypoperfusion of the flap. So when you see a pale flap, first see that how your patient is in general doing. Is there an hypotension? Is the patient is cold? Is the temperature is down? Is there a local vasospasm of the thing? You see the dressing around, there is an external kink or compression. Have you actually become very aggressive in taking the sutures, and the flap is actually very tight or not? So there can be a mechanical compression around your flap also. So when you have ruled out all these things in your ICU or in HDU, then what happens is that arterial thrombosis is one of the cause. Second is the venous congested place, which is usually with the venous thrombosis. Sometimes there is an compression or hematoma or twist or a kink in your venous paddle, which can also show a venous thrombosis. And as we have seen here, this is the flap where there is an arterial venous problem, because there is a tight suture around it, which has caused a part of the radial forearm to be venous congested. Here in a bilobe flap, there is a tight closure and a thick flap of ALT, which has closed and venous congestion here. Here there was an hematoma in the neck, which has caused a venous congestion. And here there was an arterial thrombus, which has caused the patient, the flap to be pale, and an arterial compromise was there. And patient was taken in the OT and was salvaged. So on the clinical examination and on the keen examination of the surrounding area, you will be able to find out that what is the problem and why this flap is not behaving right. So there are certain reversible and irreversible complications which can happen, and your flap can be salvaged if it is a technical problem. If your technique is a problem, there is a reduced blood flow due to various reasons, like a problem in pain control, hypovolemia, patient positioning. If there are certain irreversible causes also, like some of the vascular diseases, severe atherosclerosis in the flap, radiation injury causing problem to the intima, malformation, hypercoagulability, and certain systemic diseases. Anticoagulants, some words for that. There is a big debate on that. Many of the institute do not use it. We used to use a lot of anticoagulants with heparin and with Dextran and everything. But what happens slowly is once you are almost reliable with your technique, you slowly start using less and less anticoagulant. And it is usually an institute protocol when you are using anticoagulants, but you have to see that you don't use a lot of that. It should not cause harm. You should take care of the DVT also in your patients, and you should audit your own results about your anticoagulant protocols to know that actually they are required or not. You have to see the patient in general also, the cardiovascular status of the patient, respiratory status, retention of urine, gastrointestinal status, vascular status, hypothermia, skin, etc. Because your surgeries are usually prolonged surgeries, and the post-op period is also prolonged. So the general complications can lead to flap complications also. So the importance of being very vigilant about post-operative care is you want to diagnose the complications very early so you can prevent the failure, you can rectify your treatments, your problems. That is the take-home message, and all the complication or all the problems which happens are usually you can usually find the solution. But if you are not able to find the solution, or if you think there is something which is missing, you take help of the people around you. You know, there are smarter people in your team, and they will definitely guide you. And don't hesitate to discuss your failures. So from the failure we learn, and these complications and post-op problems are inner learning in a way. Thank you. Hello.
Yeah, it was an excellent talk.
Thank you.
Yeah, kindly. We'll go to the next speaker. Vidya,
Hello.
Adash, yeah.
Yes, sir. Yeah, that was a wonderful talk, sir. There was some problem with the mic. I was keeping on talking. It was a very good talk. And there are important, we have discussed very important aspects, especially while doing long surgeries, including microvascular surgeries. And a good post-op care and important decision makings in the post-op period is a must to get a final good outcome. That's what Dushin sir stressed on. Very nice talk, sir. Very comprehensive, good talk.
Thank you. Thank you, Adarsh.
Yeah. And I would like to hand over the mic to Divakar sir for introducing the next speaker.
It will be Dr. Vidya will be introducing the next speaker.
Okay. Dr. Vidyadharan?
Yes. Yeah, the next speaker is Dr. Srinivasan B. He's a consultant maxillofacial prosthodontist at Sir H.N. Reliance Foundation Hospital and the chief executive at Enhance Head and Neck Rehabilitation. He is also the vice president of the International Society of Maxillofacial Rehabilitation and the past executive committee member of the Indian Prosthodontic Society Pune branch. He was also invited by the World Health Organization to participate in its call for action on rehabilitation, and he's the recipient of the Biotechnology Innovation Grant by the Government of India in facial prosthetics. He has a special interest in creating cross-subsidy for non-affording patients requiring prosthetic reconstruction of congenital and acquired head and neck defects. He will be talking on prosthetics and osseointegration in head and neck reconstruction. Dr. Srinivasan, please go ahead with your talk. Thank you, sir.
Just a moment. I'm just trying to get the screen sorted out. Just a moment, please.
Sure, sir.
Yeah, okay. So thank you everybody for having invited me over to share my views with all of you. And thank you, Vidya, for a very kind introduction. Um, Today, I would like to throw some light on a slightly different aspect of head and neck reconstruction, which I feel needs some attention, especially in our country. And that's very clearly pertaining to prosthetics and integration in head and neck reconstruction. So I'd like to start the proceedings with a short video to set the ball rolling. Oh, sorry. Yeah. So I refer to these patients as the forgotten patient because we have added life to their years. All our surgeon colleagues have done a wonderful job in trying to give them a new lease of life. But the ending is not always happy. And we encounter situations sometimes where the cure can sometimes be more dreadful than the disease itself. We see patients deteriorating right in front of our eyes, and there's sometimes little that one can do. So this is essentially a call from all these patients to sometimes ask if it was actually worth surviving. So it's about time that we did something for them. So the human face is often considered to be the focal point of a person's identity. And especially in an image-driven society like ours, where facial attractiveness and symmetry are markers of health, happiness, and success, in case of facial disfigurement, to achieve restoration of what is perceived to be normal and socially acceptable is very, very important. But the human face sometimes gets altered, either because of acid attacks, which is showing a rise in, especially in our country, or sometimes a very bad accident, or it could be a result of a cancer surgery or sometimes a birth defect. And these are sometimes uh, have a very deep impact in the lives of all those who are affected. So as I mentioned, that the cure can sometimes be more dreadful than the disease itself. So these people are invisible, but their problems are very, very real. And they are not a small number. Over 75 million people worldwide, actually with some kind of facial disfigurement or the other. And a lot of these patients go through enormous physical, emotional stress. They are financially stretched and end up with a suboptimal quality of life. A lot of them survive the entire ordeal but are unable to cope up with the aftermath. It's surprising to note actually that less than 5% receive any kind of rehabilitation, while the vast majority, or the 95% of them, actually accept their physical disabilities with a fatalistic attitude. But there are solutions for such patients, fortunately, and in the form of reconstruction and prosthetics, and these can give a new lease of life to such patients in need. But what you need, if you have need, actually is a comprehensive and multidisciplinary effort to pull off something like this. So reconstruction and rehabilitation need to be planned even before surgery and need to be an integral part of the part of the workflow. And and in this entire team, a maxillofacial prosthodontist, like someone like me, can add a lot of value, because we can fabricate prostheses of different types, be it an auricular, an ocular, a prosthesis for a mandibular defect, maybe for a birth defect, as in a cleft lip and palate, or otherwise. And what do? We replace anatomic structures lost to ablative surgery with an appropriate artificial substitute, and in the process, restore optimal function, aesthetics, and self-esteem. So the process of prosthetics and rehabilitation need not necessarily start from the beginning, but the thought process and planning should start even before surgery, and that's very, very important. The key is essentially to plan surgery with the endpoint in mind and end the treatment with a functional rehabilitation. So there is, to spice up the entire conversation, this is often termed as a big fight between flaps and prosthesis for reconstruction of head and neck or maxillofacial defects. But actually it is not. There are algorithms already in literature with reasonable guidelines to suggest where, or rather in which situation one should be going for a surgical reconstruction, when one should be going for a prosthetic reconstruction, and when what one really needs is a combination of both of them for optimal outcomes. So going into a few options that we have for different kinds of defects. For a maxillary defect, you have a couple of options in front of you, and I would be essentially highlighting on the prosthetic options for paucity of time. So to start with, we have an obturator in place, and essentially the obturator is a prosthetic device which can be used to obturate the maxillary defect and restore form and function both. So the entire process involves 3 steps, each with different objectives. You have an immediate obturator, you have an interim obturator, and a definitive obturator. So the immediate obturator starts, the process for the immediate obturator starts with the preoperative impression of the upper jaw or the maxillary arch. And after consultation with the resective surgeon, a mock surgery is done on the plaster cast, and an immediate surgical obturator is fabricated. The next is process is to the next step is for a prosthodontist to actually enter the OT or the OR along with the resective surgeon, and the moment the tumor is resected, the surgical obturator is put in place with the defect molded. So immediately. Anywhere, and the surgical obturator is then kept in place for the next 2 to 4 weeks. And after that particular period, due to a change in the size and shape of the defect, you need to either convert the immediate surgical obturator into an interim one, or fabricate a new one completely. Now this is going to be in the interim obturator will then be in place for anywhere up to 3 and 6 months, depending upon whether radiation therapy is initiated or not. The endpoint of this particular treatment is the definitive obturator, which is inserted anywhere between 3 and 6 months after surgery, generally after radiation therapy as well, if indicated. And this is a prosthesis which would last the patient for at least 5 years before it needs to be changed. And there can be a couple of follow-ups in between to ensure that it fits well. Sometimes you do not have sufficient teeth to anchor the prosthesis, and you may want to resort to an osseointegrated implant to support your obturator. So even right from the immediate surgical obturator stage itself, you can place these implants to anchor your surgical obturator. So the implants can be placed at the time of ablative surgery itself. If there is no radiation therapy, you can place these implants, as I mentioned, at the time of ablative surgery itself, or if either the patient or the resective surgeon is not comfortable with the idea, you have the option of placing these implants at a later date as well. If radiation therapy is contemplated, it may be better to place the implants at the time of ablative surgery itself, although you have an option of placing the same after about 12 to 18 months post-RD. The reason being that when you place it at the time of ablative surgery, you are able to offer a radiation-free environment of about 4 to 6 weeks before for the implants to integrate with the bone. And then you have a definitive obturator where after 3 to 6 months you are able to place a more definitive prosthesis, and in this particular situation you are able to use the integrated implants and connect them to an obturator prosthesis. Sometimes the defects are extensive, and you may not have enough the teeth which are necessarily sound to support your prosthesis, or in situations where it's a bilateral total maxillectomy, you may decide to go in for zygomatic implants, which today are a viable alternative to free flaps, especially for very large defects. And wherein you can use them either in isolation or in combination with some soft tissue flaps, and end up with a functional prosthesis and effect a functional rehabilitation in the process. Free flaps are always an option today. And then if there is no radiation therapy that is contemplated, you can place the implants if immediately at the time of primary reconstruction, and then go, and after healing, you need to go through a process of flap debulking and then connect the implants to a prosthesis, again to replace the dentition. Now, if the process is involving, it's going to be either a secondary reconstruction, or in case of benign lesions or non-oncologic reasons for reconstruction, the process of prefabrication of the fibula can be an important or can be a useful adjunct in the armory of the reconstructive team. So, and if radiation therapy is indeed contemplated, this is where it becomes a gray area, because there is a lot of debate to suggest whether the implants need to be placed at the time of reconstruction or to be delayed. So that's a gray area and open to debate. But either ways, the prosthetic planning to ascertain the correct three-dimensional position of the fibula is a must-have, because we often encounter situations where the reconstruction looks wonderful visually, but when you go inside the oral cavity to commence procedures to replace the dentition, you realize that the fibula is unfortunately not in sync with the antagonistic dentition, and hence makes prosthetic rehabilitation very, very difficult and complex. And doing a free flap does not necessarily mean that you need to go in for an implant bone prosthesis to replace the dentition. If you have reasonable number of teeth to anchor the prosthesis, you can give a non-implant bone removal prosthesis as well. And the reason I'm highlighting is that sometimes it's conceived that that a free flap necessarily needs to go with osseointegrated implants to be able to replace the dentition. It's more a situation-based decision that that needs to be taken. And here again, I would highlight a sound prosthetic planning to ascertain the correct three-dimensional position of the fibula, which is definitely a must-have. So pertaining to implants and radiation therapy, I believe that the implants can today be placed at the time of ablative surgery itself, for the reason that I already mentioned. And for any reason, if we are not really comfortable with placing those implants at the time of ablative surgery, and if radiation therapy is indeed planned, then it is safe to wait for another 12 to 18 months before implants can be planned. Quality of life studies indicate that there is very little to demonstrate a difference in the functional outcomes between obturators and flaps, and speech and swallowing as well are comparable between prosthetic intervention and flap reconstructions. So depending upon the size and nature of the defect, you can choose based on existing algorithms available in literature and make the right choice for your patient. Not to forget that the patient also needs to be at the center of this, is that should be also included in this decision-making process, because as caregivers, sometimes we tend to prejudge patients and try to make decisions on behalf of the patients, because we have encountered situations where we are suggesting an obturator for the patient, while the patient has very clearly outlined that he does not want a removable device at all in the oral cavity, and vice versa. So I think the patient, it's very important to include the patient in the discussion when these reconstructive decisions are taken. Moving ahead to soft palate defects, if more than half of the levator veli palatini muscle is resected, that is, if the resection is going to be crossing the midline, I think it is always better to go in for an obturator. And should surgical reconstruction be contemplated, it should be an option, I feel, only if less than half of the soft palate is resected. This I say this because when there is no flap that can predictably reproduce the dynamic nature of the soft palate. And hence, there are situations where a prosthesis can actually can give better functional outcomes than a flap. So how do these obturators look at rest? There will be a space around the obturator. This is important to note, because very often when we are examining clinically, and the patient is not swallowing and is at rest, there one would see a space around the obturator, and this should be perceived as normal. It's only during contraction when the lateral and the posterior pharyngeal walls come in passive contact with the obturator, and that's when they effect a velopharyngeal closure and a functional prosthesis. So this is important to note. We can always audit whatever we have done by a nasal endoscopic view of the prosthesis, because it's not always easy to visualize the velopharyngeal complex and understand if our prosthesis has actually obturated the defect completely. So nasal endoscopic view can be a good adjunct to audit whatever we've already done. Moving on to mandibular defects, the surgical reconstruction is the gold standard, and again, if we were to see a vast many reconstructions, at least in the ones that I have been observing, it's not uncommon to see these kinds of results where the fibula is not really in the right three-dimensional position, and it becomes a very big challenge for us to replace the dentition. But these situations can be avoided. So when you encounter a situation with the gross malalignment of mandibular segments, it is best to start the entire reconstruction process with occlusion as the starting point, or ascertaining the location of the dentition to start with, and then aligning the position, and then planning the positioning of the fibula rather than the other way around. Now, this planning can today be done with CAD, as we've already seen earlier in the day, but this can also be done without the use of expensive softwares, and today 3D printing is not really that expensive anymore. So you can print the models of the mandible and the fibula and replicate the entire process of CAD by actually taking a hacksaw and then effecting the osteotomies and putting them all together on a 3D model. So what's important is the central principle of ascertaining the positioning of the dentition first, or the occlusion, and then moving backwards to ascertain the position of the fibula. So you can, and if you should you want to translate this entire planning into the OT, you need certain guides that can help you to translate your entire planning into the operation theater. So I would like to just share a few steps that we would generally do. And now this is a process for prefabrication of the fibula, which is a process which is clearly restricted to either secondary reconstructions or benign tumors, or in situations where, for example, trauma, if you should you need where for non-oncologic reasons. So in a situation like this, in a nutshell, what we attempt to do is to plan the entire process, which is it's a prosthetic driven procedure, wherein you ascertain the position of the dentition, work backwards, and place the implants first in the leg, wait for the osseointegrated implants to integrate in the fibula for a period of about 6 weeks. And then after 6 weeks, you harvest the fibula, and in the intervening 6 weeks, you keep the dentition or the prosthetics ready. So at the time of stage 2 surgery, when you harvest the fibula and take it into the oral cavity, your prosthesis is already ready and ready to be inserted into the oral cavity on the same day, what was earlier referred to as jaw in a day. So we can just go through a few steps. So after prosthetic planning, we first place the implants. The size of the implants are already ascertained, and then inserted into the fibula. So the stent is positioned, and the osteotomies for the osseointegrated implants are then effected. So next comes the actual process of placing the osseointegrated implant. Now these are essentially titanium fixtures coming anywhere from 7 millimeters going right up to about 13 or sometimes even 15 millimeters. So here generally a 10 millimeter implant is and a 3.5 millimeter diameter is generally fits most fibulae. So once the implants are in place, they are all covered with a skin graft, and then a membrane is placed over them. The purpose of putting a skin graft in place is essentially so that in stage 2, when this entire complex is taken into the oral cavity, the entire skin graft would epithelize over a period of time and result in keratinized tissue around the implants, which is so very important. Placement of a membrane makes it easier for us for the surgeons to dissect and then separate out that particular area easily. Now this becomes after stage 1 surgery. There are a series of laboratory steps in the process to fabricate the prosthesis, and also tweaking of the final plan, because there can be a slight difference between the planned positions and then the actual positions. Now, based on those, on that, you create the stage 2 guides for stage 2, and you can see that now it becomes very easy to effect the fibular osteotomy. You can see appreciate here that the implants are already there. They have already integrated, and the skin graft has been well taken up. In the next step, it's actually involves the insertion of the prosthesis on the over the implants. Mind you, at this stage, the fibula has not been separated out yet, and so the prosthesis is already inserted over the fibula. So this is how it would generally look. And especially in situations where multiple segments are involved, the prosthesis can actually guide the process of getting the fibular segments together. And last, when this entire thing is taken into the oral cavity, it's in a perfect position, and then you have the dentition replaced then and there in the same procedure. So if these procedures are well planned with essentially with a multidisciplinary team, wherein inputs from the surgeon, the maxillofacial prosthodontist, the laboratory technician, the resective surgeon, they're also, it's so very important to get put all the entire jigsaw puzzle together. And if a team is able to get this in place, then I think such functional outcomes can be expected, where where patients are happy with the outcomes, not necessarily restricted to facial form, but also with improved parameters of mastication as well, and with their dentition as well replaced on time, the acceptability of the entire treatment is definitely much better. So a good prosthetic planning is going to be fast tracking reconstruction and rehabilitation and result in optimal functional outcomes, and eventually lead to an optimal quality of life. So in a nutshell, if there is no radiation therapy planned and if fibula is going to be used for primary reconstruction, implants can be placed immediately, and then following a process of flap debulking, connect them to implants, and then result in a functional prosthesis. In this situation, you are placing the implants immediately at the time of ablative surgery itself. Alternatively, you can choose to place the implants at a later date as well. And as I mentioned, that in case of secondary reconstructions or in case of benign lesions, you can go through the process of prefabrication. Again and again, I would like to stress, prosthetic planning is a must-have, and to ascertain the correct three-dimensional position of the fibula. This is something that I would be saying repeatedly during the presentation, essentially to drive home a point. So again here, as in the maxilla, in the mandible as well, you need not necessarily have place implants every time to replace the dentition. If you have good sound teeth on the contralateral side, you can use them to anchor a prosthesis, and it can be non-implant bone as well. Moving on to facial prosthesis, if there is a defect in the ear, we can go ahead and fabricate an auricular prosthesis. Now these are essentially silicone based with customized. The colors can be customized, the size and shape can be customized. It involves a manual process in which involves sculpting skills. It's an artistic procedure. But very often you can't make out really that if well done, you can't really make out that it's a prosthesis. And if you have the eye missing, you can go in for an ocular prosthesis, and if there's a complete exenteration, then you can go in for a silicone based orbital prosthesis as well, as in this particular situation. Now, in each of these situations, these prostheses are manually fabricated. But now we've come out with this Made in India protocol, wherein you can do this entire process digitally as well. And digital does not necessarily mean it is going to be expensive, because it all depends upon. We very often end up calculating only direct costs of treatment, but do not calculate the indirect costs of treatment, especially for procedures where patients have to travel long distances, and there's an indirect cost of boarding, lodging, travel, and loss of pay. So if a digital technology can actually help in effecting remote healthcare delivery, and using a combination of digital scans, good CAD designs, and 3D printing, you can effect these treatments even at remote locations. So our team is currently working on the use of the mobile phone as a scanning device, because currently we believe that the currently available digital scanners are prohibitively expensive and hence not scalable. especially if we want to make care more affordable and accessible. So our team is currently working on the use of the mobile phone as a scanning device, and we've already done some test cases. So our current solution is actually involves the use of the mobile phone as a scanning device, captures skin colors with the camera, converts the entire process into a CAD model, and then translates this color into all this information to result in a completed silicone prosthesis. And in fact, the prosthesis fit supervision over video call is something that we did during the recently concluded lockdown. And this was a patient in Sydney. So we were able to effect a treatment for a patient in Sydney sitting right here in Pune. And all we did was to supervise the fit over a video call, and thankfully it fit. So digital technology, we believe, is going to play a very important role in making care affordable, accessible, and enhance reach. And this is not going to be the end. Very soon, the technologies like artificial intelligence and augmented reality are going to play a very huge role in changing and creating a paradigm shift in the way prosthetic rehabilitation is going to be effective. And most importantly, all this is currently being done in India. So it is possible even in a resource constrained country like ours. So especially with oncology, because a lot of the cases that I end up treating are related to oncology. The objective of oncologic care is cure, and there are no two ways about it. The definition of cure was always restricted to disease control, and for a long time this was the definition. But I think there is now a change in the goalpost, and cure today, there needs to be a revised definition of cure, which should also include a functional rehabilitation, which is very much in sync with what the WHO also believes in, and wherein they have highlighted the need to scale up rehabilitation. And this is where I feel that as a team, we need to be talking henceforth not necessarily about cure and disease control, but also on how the patients are going to survive the aftermath of care, and change the definition of cure to include rehabilitation as well. So with this, I would like to sign off, and I would like to thank everyone once again for a patient hearing on a Sunday evening. I hope we have enough food for thought. Thank you.
Thank you, Dr. Srinivasan. You've given a lot of food for thought, and thank you for sharing your experiences on prosthetic functional rehabilitation to improve the patient's quality of life. And it's also interesting to see from India, you're promoting remote healthcare delivery all the way to Australia. So that's also, it's literally on the cutting edge. Thank you, sir. We'll now go to the next talk. I would be introducing the next moderator, who would be Dr. Sajid Babu, who is the Associate Professor at Malabar Cancer Center. He's a well-known teacher among the head and neck surgeon circle, and he has a special interest in reconstructive surgery, and is well known for his local flap reconstruction. Sajid sir, please could you introduce the next speaker?
Our next and the last speaker of the day is Dr. Subramania Iyer. He is a very well-known international and national faculty. It doesn't need an introduction here, but to all those people who are not familiar, because we have few delegates who are from outside as well. Dr. Iyer is currently professor and chairman of plastic and reconstructive surgery, as well as center of head and neck surgery and oncology at Amrita Institute of Medical Sciences, Cochin, in India. He has special interest in head and neck oncology, microvascular reconstructions, hand transplant surgery, aesthetic surgery, ear reconstructions, facial paralysis surgery, and as far as I know, anything that is new. And Sir has done various fellowships in tissue engineering, as in laryngeal surgeries, etc., and craniofacial surgery. He was the first, his team was the first to do the double hand transplant in Asia. And also he has done the first tracheal transplant in India. Over to Iyer sir for his talk on reconstruction of unusual head and neck lesions.
Thank you, Sajid. Thank you very much. I'm happy to be the last person because I started this meeting, this reconstructive session. Jayant gave me the opportunity to give a welcome initial talk, and then finally the last lap is also mine. So quite, I can maybe the only person to claim that I was throughout the meeting. So let me start my talk. It is something which I don't think there is anything fanciful in this, but I thought, let me open it. Yeah, it's okay. Yeah. So reconstruction of unusual defects. Unusual can be defined by a lot of people in lot of different ways. So something is usual for somebody, it can be unusual for somebody, unusual for somebody can be usual for somebody. So it's a vague sort of term. But anyway, for this presentation and finishing my talk, I thought I will put it as this one. These are all few examples of cases, and then something to learn, some principles of reconstruction to learn from that. That's all. Nothing big about the talk. So complex reconstructive requirements, age of the patient, underlying pathology, and distortion of anatomy. I just conveniently put it because these were the cases which we had done with under these headings. So complex reconstructive requirements. See again, the methods which I have shown in these cases, which we have done, might be able to be done in differently. But just as a principle, I'm, taking this as a own principle sort of, suggestions only. Now, this is a huge defects. Like salvage surgery can be extremely big defects. This lady has entire. This is something which we all see nowadays, where you have the entire cheek, mandible, and then the inside from maybe retromolar trigone or the upper alveolus to the midline goes. This is something very usual. And when there is a scope for mandibular reconstruction, then it becomes a different sort of entity in reconstruction. Many times you wouldn't like to reconstruct the mandible because the patient has already a trismus. That is something which we believe that if the patient have a severe trismus, we shouldn't reconstruct the mandible. But if it is quite nice and then the disease as such, you think that it is okay and the patient is otherwise so keen, and then you could achieve that, then in that case, one see, this is the resection defect. In those these are the cases where you would think of not stretching a single flap to do the job. So there the principle should be that you should be able to do two flaps, and this is an ALT flap and a fibula flap. ALT and fibula. So fibula is one of the flaps that is essential for this if you are doing a mandibular reconstruction, whereas the ALT can be replaced by pectoralis major or delta pectoral or any of those things, or a radial forearm, depending upon the soft tissue requirement. The advantage of doing like this, it saves you from lot of complex planning, because you have a fibula with a skin paddle, gives some, two elements of the defect are covered. The bone and either inside lining or outside cover is taken care of. Then you need to worry about only one thing, which you can do whatever you want. Currently, this was nowadays what we do is to have the fibula inside, the skin paddle inside, and use a deltopectoral outside, so which takes away the necessity of two free flaps. This is again, these are all cases where you think that whether it is to be operated or not, but this patient doesn't have a lymph node metastasis. So generally some of them do well, so you have to give a chance. There is no distant metastasis, there is no regional metastasis, then you give a chance and do this. They are also here extremely, big defects. You may need to think of two flaps. So large sort of defects, then you think of an unusual situation of using two flaps rather than stretching it one. This is an ALT with a radial forearm, I think, or a pectoralis major, what was that, inside. So always think in terms of, in these unusual situations, simplify your reconstructive logic by using two flaps. So complex skull base defects like this. So you can see the oral cavity to the brain is a single place. Yeah, this thing. So here a reconstruction is very, very important, and you compromise on your reconstructive methods, you are doomed to fail, and the patient is doomed to die. So there also again, you have to be bit. This is an unusual situation where you need to. This was a patient who had a rectus and ALT flaps together, two flaps. So this is the patient afterwards. So in an unusual situation of very large defect, very morbid sort of, if you fail in a flap, if you are really having a morbid sort of thing, you think of simultaneous double flaps. I wouldn't say this is a paper we published, but I wouldn't say harp on double free flaps. It can be double flaps, one free and one pedicle, or even two pedicle if it is okay. Now, unusual situation, posterior skull base. This is a tumor, which is a chordoma, which needs to be excised. This is the, these vertebra has to be removed, and then the soft tissue will go off. And this is a congenital defect or not malformation where you need to stabilize and then you need to put it. Plates can be used, but this was specifically requested by the neurosurgical department that they need to have a skeletal support. And maybe it is looks very difficult, but if you use a fibula like this, it works extremely well. And it's only the access, putting the fibula with a plate and then putting the pedicle just comes out like this, so it is very easy. But access to that place is much more difficult, where we will need to do a midline mandibulotomy and then glossotomy with a Lefort type of down fracture or palatal split, all those things. But once you have access, putting a fibula there will be not very difficult. Again, unusual situations like this with a huge defect like this, where the patient wants to have some amount of reasonable normalcy, you need to think out of box in a way. No, I wouldn't say out of box, always in box. Use all the methods in plastic surgery to get it right. Don't harp on that you'll do only free flaps. You do a simple fat injection, or implant, as Srinivasan was saying, that you can use a implant based support for some processes. So combine everything. It is just, I'll just zip through these photos. So she had a free flap first to give it filling. Then the free flap, the fat was modulated by taking out by liposuction or transferring by as a pedicle, and then getting it into this thing. Say again that paper strip, this is a fat flap which was turned over like that, and fat flap turned over like this. So these are the flaps. So, and they sling through the thing into, take the commissure up, and the autoplasty. Now, again, implant based orbital support. This is again fat injections, and finally like this. So if you look at it, lot of techniques has been used for in these unusual situation. It took 16 procedures in 7 sittings to get this result. Age of the patient, unusual defects, unusual situations, when the age of defect is patient is very important. Typical example is a severe fibromatosis of the mandible, where you need to resect it, and then you have to resect the entire thing with the temporomandibular joint and the mandible, and then you need to provide a bony support, as well as which allows growth, as well as a temporomandibular area reconstruction. See, currently temporomandibular joint reconstruction and replacement, adding the joint to the fibula is all okay. But in a pediatric age group, it is very difficult to use it even now, because of the fact that these prosthetic joints longevity might be a problem. So you have to provide a growth center. Simple rib is okay, but fibula with a the fibular growth end is on the top, which can be used, but it's extremely difficult to get that into shape for a mandible. Not many people have used. So the rib, this was one method which you use. We use the rib with the serratus anterior because the blood supply for the rib was from the serratus, and this is the growth end. So this was used, and then this is her growing slowly. You can see that she has had the mandible growing with the ages, with the years, and this is the mandible which has grown. But you can see that it's very thin, and then you need a dentition now. This was about I think in 2004 or 5. So at that time we didn't have any idea about the implant placement and all those things. Anyway, later on what was done was to augment the bone like this and place the implants, and then rehabilitate with the implant based denture. So this is her. Now, underlying pathology. This case will demonstrate to you unusual situations because of the underlying pathology, which was a huge vascular malformation. So again, we all see lot of vascular malformations, and the vascular malformations which are so difficult to treat are in the head and neck, especially if they are high flow. What you whenever vascular malformations come to you, everybody will think in terms of lot of things like embolization or sclerosis, and then debulking or cauterization. But majority of the cases, why we fail in AVMs and all is a uh, lack of bold surgical clearance. Unless you treat them as cancer, like resect the entire thing, the entire nidus, entire affected area, and then reconstruct them, it is bound to fail. So there, it is a very unusual situation. I think it is much more difficult than cancer because you are working in an area with a high blood flow, and then you can have a severe blood loss. You can lose the patient, and your reconstruction with a flap or whatever is that in a bleeding bed, all those things have to be taken care. This case will demonstrate to you some extent the difficulties and how we overcame. This was a lady who had a AVM with a mixed sort of thing, and then you can see that it was thinning in area, and it was going to cause life-threatening problems because she had a couple of episodes of. So you can see the MRI with a huge malformation, and then you can see that the extent is also huge, going into the paraspinal and parascapular muscles, and you can see the the blood vessels which are supplying it is subclavian and the common carotid. Now, looking at it at that time, this was the time when we thought of what is a method of providing a sort of safe surgery without blood loss, not preventing catastrophic blood loss. And then the idea of putting the patient in a cardiac bypass and thing came, and everybody agreed, and the patient also agreed, and the family agreed, and then we thought of putting it like that. And the patient was taken with the consent for all these things, and they initially we placed the catheters, but we continued with the surgical procedures without putting the patient on bypass for the maximum possible time, so that we can limit the time of putting the patient on bypass. So once that critical time was over, I mean the area where we had to work on a bloodless field, we put the patient on bypass and we could remove it. Now, the challenge is that when you are putting the patient on bypass, the patient is heparinized, and then you have to take away the effects of heparin. All these things happen, and then at that time, reconstruction is extremely difficult, and you are not sure about your hemostasis. Whatever you do, the best thing to you to do is to pack the defect and leave it for 3-4 days, even 1 week. By that time, all the bleeding, whatever is that, it will stop. But then you should find the ideal time for reconstruction. This was a patient at that time. We left it for 3 weeks, in fact, so that everything becomes clean. And then at that time, took a big ALT, contoured it, and put it across like this, giving an excellent, reasonable sort of shape. And then she was, she didn't have any issues with the regarding to any of the problems, cardiothoracic bypass or excision. So this is happily lifting her baby. Lastly, uh, unusual defects and cases due to the massiveness of the disease process and distortion of anatomy, which you heard excellent talks today on all the 3D planning. Prabha madam talked to you about massive mandibular defects, and then Srinivasan talked to you about prosthetic. When the disease is so big where the anatomy is distorted, you should have some idea how to reconstruct that area which is being uh, resected with some amount of anatomical resemblance, with a reference being you have to get the reference point from somewhere. These are the cases which will demonstrate that. This is a massive tumor, osteosarcoma mandible, hemimandibulectomy done 10 years back, recurrence treated 6 years back. At present, this is growing, and then PET scan is negative. So, and then you can think whether you should treat or not. Since the PET is negative and he's otherwise okay, healthy guy, we thought we should offer treatment. Where do you get the mandible? There are a lot of challenges in this unusual case because one mandible is not there. The other mandible is totally distinct. So you have to have a sort of some amount of resemblance of mandible. Then you don't have any mandibular muscles. You don't have bilateral, all these masseter, and the one which closes or one opens won't be there. So there will be the open mouth or whatever is that is very difficult to. Mostly, we thought that we'll have difficulty in getting a muscle to close the neomandible. That would have been a problem. Anyway, this is the tumor, and we went ahead with reconstruction using a fibula with a sort of standard mandible which was recreated. But again, how do you suspend it? There's nothing to suspend this mandible here, even though this plate is only for contouring the thing. So how we suspended it was to the top, and then we had a plate going into the zygoma here for the temporary basis, and this plate was going through the skin flap into the maxilla as a temporary basis. So it worked. It worked, and this was the way it was reconstructed, and this is how it occurred. But now he had a lot of problems. See, as I told you, the mouth opening and closing would have been a problem. So we tried to think of putting a temporalis muscle as a sling to get it closed. In fact, we tried in this sitting, which didn't work. Then at present, what has been done is to have a good sling from here to here with some amount of mouth opening, so that the lip will close, not the mandible. Mandible is almost in the semi-open position, whereas the lip is the one which is closing the defect. But much better than what he was, and he is able to eat himself. Unusual encephalocele, huge one, Adivasi patient who has been roaming around, who partly not offered treatment, partly because of his situation. He then left it untreated for some time. Brought to us with the help of tribal welfare officers and all those things. Now, what again? Basic plastic principles, craniofacial surgery, you have the defect here. So have a pediatric craniofacial surgeon, pediatric neurosurgeon. We opened up, took the everything, and then this was the encephalocele. Here, the crux matter for the reconstruction is use the tissues what is available, and then add the tissues So this was a craniofacial part, and this is the plastic surgical part where we could use most of the tissues, and then we use the bone strut for creating the bone and got it like this. And I think it's the last case. This one, Amar Samad, is again very unusual case where you can see this is he is a from a tribal village in Jharkhand. This is a fibromatosis, which is ossifying fibroma, which is again benign but has grown. You see, this is he had he was just left. Father was no more, deserted by mother, and then he was just sitting like this in his tribal village doing nothing. And the again some sort of intervention by lot of people involved, social workers, and then the tribal there is a very good organization in Jharkhand which was which was taking care of this child to come over here. So you can see this video. If this work, you can see that uh, this is the way his mouth was, and you can see the way the eye is working. So everything is stretched. So in fact, if you are reconstructing, you would try to save this eye, but then you don't have a clue. I'll show you the this is the way he was walking around. This is not moving. Okay, that's not. Anyway, go back. See, this is the X-ray. You can see the huge bony lesion involving the entire maxilla, and then orbit. Orbit is seemingly very bad, but you saw the eye moving. So the structures within the orbit should be normal. So the challenge was to have a mandible and maxilla reconstructed, orbit reconstructed. With where do you base it? We had to take the opposite orbit as a base, and then mirror image that and get a stereolithographic model, and then take the mandibular teeth as the as the template for your future maxillary position in an inverse planning mode. And then that is how you got this. And this was a tumor taken out with the entire palate. And then the challenges would have been all these things. You had to think of how to do all these things when you're reconstructing. Fibula was our savior, and then we could use the fibula again for filling the hole in the palate, and then all these things support the eye. And this was a strut of the fibula which was pushing the mesh up, because there is not enough fibula to give a usual L-shaped type of reconstruction. So we use the fibula to use as a strut to cover the mesh, which worked well. And finally, supporting the nose with a fibular, again we use the fibula only for as a cortical bone graft, and this was him like that. See, this is the method, and this is the final bony sort of position, which was extremely difficult to achieve. You had to pre-bend the plate like this into the temporal area for getting good hold of that. And this is him after the surgery, and then this was the video. If it works, we'll show. Yeah, this is when he started walking around the hospital and going to the canteen and then eating for the first time. After about, he said that about 8 or 9 years, he was just going out and eating for the first time. So let me finish here. So I just talked about these things to give you an idea of unusual situations and unusual methods of reconstruction. Thank you very much. This was a team effort from the whole Amrita group. Thank you very much. And let me congratulate Jayant for organizing this great event for last 1 month. It's a really commendable task for this perseverance, and then doing all these things all this month. Thank you.
Thank you, sir.
That was astonishing presentations and cases. I think we could expect nothing shorter or smaller when IR sir is presenting. And I don't know, after 10 more years, what kind of cases sir would be presenting. So please don't frighten us anymore. It was very nice to hear all those. Over to Dr. Jayant. We are going to have the more sessions, other session discussions. So Dr. Divakar or Dr. Jayant
Yeah.
can take over.
Can we go for the discussion?
Yes.
Sajid sir.
Yes. The first presentation was from Jay. I think Divakar is there.
So a couple of questions to Jay. Just a clarification, really. Both the cases that you showed of tracheal resection anastomosis, was it a circumferential resection of the tracheal segment, or was it a wedge anti-resection of the trachea? It was not entirely clear in the photos. I just wanted to clarify.
Good question, Divakar. The first case actually is pretty much a circumferential excision because we removed the 5 rings. So if you don't possibly resect the posterior tracheal wall, when you pull the rings, that will form a kind of ridge. That's why we resected it. But while you resect circumferentially, you have to be very careful with the anterior wall of the trachea, posterior wall of the trachea is the anterior wall of the esophagus. So you have to resect a little bit only the mucosal part. If you go more deep, it could cause potentially a tracheoesophageal fistula. But the rest of the cases, if you resect only 3 rings, technically you don't have to resect the posterior tracheal wall. It just forms a small ridge, but it should be fine.
Thank you. Just one other point. It's a clarification, really. You said that you always do a vertical incision for adult tracheostomies, but that is not the most common technique used worldwide. In fact, the recommended, taught, and most practiced technique of adult tracheostomy is to remove an anterior tracheal window, or you do an inferiorly based Bjork flap. And as long as the window is not very big, as long as it is just snug to accommodate a tracheostomy tube, it's a very safe tracheostomy to do. That by itself doesn't lead to tracheal stenosis. The most common reasons why there is adult tracheal stenosis following tracheostomy is first, very high tracheostomy near the cricoid that will cause collapse of the upper tracheal ring. Secondly, pressure from a hyperinflated tracheostomy cuff that will cause pressure necrosis of the tracheal mucosa. And thirdly, a horizontal incision between the tracheal rings. And if you try to force the tracheostomy tube through that small narrow incision, it might fracture 1 or 2 tracheal segments and cause collapse. And later, after decannulation, that will lead to a tracheal stenosis. But creating a window or a Bjork flap is in fact the most practiced and probably the safest technique to do a tracheostomy.
I agree with you. Making a window is the safest technique for tracheostomy, but in my experience, especially for tracheal airway center, 8 out of 10 patients, it's all due to the tracheostomy done by surgical team. It's actually interesting to say that it's not done by the ITU tracheostomy people. ITU people, they don't make a window. They actually, it's a percutaneous trachea. They go through intertracheal rings. Technically, it means they're making horizontal incision. Actually, they're not. It's actually, when you go there, that's how it is there. So when you make a vertical incision, it is not, I totally agree with you. Subglottic stenosis is caused by incision in the first tracheal ring. So the recommendation is more, or practical recommendation from my institution is, you start a vertical incision from the 2nd, 3rd, and 4th. Then if necessary, you just make a little bit cruciate incision. So the idea is, it shouldn't collapse. See what happens when you take a big window, the trachea is not a complete ring. It's a D-shaped ring. So when you take a centimeter of window, then you leave with 2 tracheal rings like unsupported. When the patient has got a long tube or big tube, then both side flanges starts collapsing. So that's why you get apical kind of or vertical deformity type of thing. Or sometimes if there is a bigger incision, then the cartilage starts collapsing like this way. So that's why when you look at the cut section, you all this kind of deformity, that's where it happens. It's typically due to making a window, but it's rare, but that's what our experience. But when you ask for the safest experience, making a window, because it's very much depends upon preventing the tracheostomy related immediate complications. But for long-term complications, that's what it happens.
Thank you.
What are the other precautions that we should take to prevent tracheal stenosis, Dr. Jay?
Other precautions, it's a good question. Laryngeal reflex is considered as one of the cause for idiopathic stenosis. So some cases could be considered, for example, fundoplications. If you think there's a repeated acid comes up, that is the prevention. The second thing is regarding the trauma. In trauma cases, keep close eye on this because you guys are treating more and more trauma kind of cases. There's a maxillofacial injury. Think about there is a possibility of tracheal injury which is unnoticed. Then it may not be noticed immediately, but over the years, and they develop this kind of problems with the breathing. That means the cartilages are collapsed and crushed, then it heals with the fibrosis, then it causes stenosis. So the trauma, the third thing is ventilation. It's nice to do tracheostomy. If you keep a patient intubated for more than kind of 2 weeks, there's a high risk of developing tracheal stenosis. So early tracheostomy is recommended, irrespective of most of the tracheostomy is nowadays done by anesthetist by percutaneous trachea. So that's the safest method.
Do you see any increased incident between the percutaneous and the traditional tracheostomy?
Actually, it's a traditional tracheostomy, there's increased incidence. Percutaneous tracheostomies are fine. And moreover, increased tracheal surgical tracheostomy is done by surgeons because it's biased. The easy tracheostomies are done by anesthetists. If it is a difficult case, it comes to you anyway.
One more question which I would like to ask is regarding the cuff-related issues. Have you noticed any tracheal stenosis coming out of cuff-related issues, like the pressure monitoring is not done properly, or the breathing was not done properly? So that kind of stenosis usually happens down, right? So have you encountered those kind of stenosis?
That's a very good question. To be honest, that's one of the reasons for early tracheostomy, because you can't maintain the pressure with the endotracheal tube effectively on a long-term basis. So high volume, low pressure tracheostomy tubes are generally safer because the tracheal stenosis as well as subglottic stenosis, that the blood supply is very precarious, especially the mucosa, and tend to heal like a more circumferential scarring way. So yes, the low pressure ones are good, but it's a debate again. The low pressure ones, the anesthetists and the ITU people will struggle to maintain the oxygenation. So there will be a leak, and so there is infection. So many things. It's a complex problem.
Next, moving on to Dr. Prabha Madam's presentations. Madam, I have one query. You said you are interested in secondary reconstructions. So in those cases, what are the problems that you face and how do you tackle them? Because we know there are going to be problems, many problems. How do you tackle them?
Mainly the post-RT, but if the reconstruction is not done, you really cannot guarantee that your bone or the joint which has written, like in a posterior segment or in heavy mandibulectomy done, where the patient has received RT, to shift that rotated bone back into its socket and whether it will stay there and it will work, it's very unpredictable. So secondary reconstructions, you need to think 100 times before you venture in. If there is a recurrence, you have no choice. But if you are going in and per planning, I think there you requires a lot of planning with the CAD-CAM or what not CAD-CAM, stereothermic models and everything, and whether the mandible will shift back in position, then only you will be able to do the justification to that. And if there is severe trismus, that's another problem. And if the tongue is sunken in, you can do the mandible reconstruction. But the tongue which is stuck in an odd position, you just cannot revive that tongue back and bring it up and stay in its original position. That is a real challenge, and that I think is very difficult. Mandible reconstruction may be relatively straightforward, but the tongue which goes and gets stuck because of post RT, it's very difficult to get it back in position in an upward position, or it will look like it is sunken in a well. So you cannot, one should be very careful when you're giving any, don't give a very bright picture to the patient that everything is going to be very smooth and normal and everything will get back in position. I think you need to really counsel the patient very well. You'll require cerebellotherapeutic models. You may have to do certain exercises for the patient to shift that bone in position. May require an arch bar and just rubber bands for that it doesn't go back. So to get it out of that mandible's memory, that position, may have to put patient again back in an arch bar position and rubber bands to get it back in position. And the problems, I think post RT anastomosis, maybe the risk is not very high, but it is still relatively risky. And if your fab fails, then what patient was, you make him worse than what he was. So that's why you need to counsel the patient very well, do the planning very well, each step, how it will move, what would be your line of management with that, how it will move, do sort of a mock surgery. That mock surgery possible only on the models, but the tissues may not behave like the model will behave. So everything keeping in mind, maybe patient will again require some minor procedures afterwards. And the risk of exploration and the loss, and then again he will be back to what he was worst. So for us it is a statistics. For whoever that, whatever patient that affects, he is the person who is going to suffer most. So you really need to think 100 times before you go in to do a secondary reconstruction post RT. Without RT, like ameloblastoma, they think tissues shift. But it is really challenging to do. But I think they deserve also. So somewhere we have to start doing it, and then only we'll realize what problems we'll face more and more.
Also, to add on to that, most of the time the reconstructions will be primary, but the secondary would be mostly that there was some issue in the primary setting. So that may provide the secondary as well. Maybe that we have done a fibula flap for the mandible or some other flap, and it just failed, and then you are going to do that.
Yeah, but then the patient has received radiation, that changes so many things. Right now, I have a patient whose one fibula failed, and they do DPP-MMC, that failed, then another fibula failed, and now again he wants something to be done. So I really don't know when he comes to me what I'll be able to do.
That is my second question, which I wanted to ask. What is your preference? Even IS sir can also add on, sir. When you have long defects, fibula is the best, we all know. But then if fibula doesn't work for various reasons, what is the next choice?
Next is like ISR has done a rib or a lateral border of scapula. But lateral border of scapula, you have a limit. I think you get about 12 to 14 centimeter of bone maximum. And I think that lateral border is almost like an fibula, thickness wise. So that is one option, or you have an iliac crest, which we can do.
One case which we did was a iliac crest from angle to angle, because that was again a failure of fibula on the table, and then couldn't do. We had to
but
do.
If you take the curvature of the iliac crest, it almost will give you like an hemimandible.
It is the posterior cut is the most difficult thing.
Yes.
You have to go and get it.
Yes. If fibula is no option, but then you have no option but then to go to other places.
Dr. Carl, you have some other option?
About?
Doctor, I was asking another.
I've never done it, but there's some work from China, and they do the spine of the scapula together with the medial border, and by cutting it, they get a kind of hemi-mandible, and that can be transferred without an anastomosis pedicled on the trapezial system.
Spine of scapula.
I've
Yes.
never done it. So
no, I have also read about it, never done it.
Yeah, but it sounds interesting, at least in these difficult cases where you have lost the second fibula. That's what I would try. I would not try the DCIA because the vessels are very small, and if you have lost two fibulas, going for very delicate vasculature and trying to reconstruct the mandible from ear to ear with a iliac crest graft, that's very difficult, I think. So if you succeeded with that, that's congratulations.
We have Dr. Dushyant and Dr. Bipin and Dr. Vikram Kekatpure also on the panel. Maybe they can give from their experience also suggest. Thank you.
Vikram,
Yeah, Sajid.
sir, your experience, sir.
Yeah, so I think the best suggestion which I can give is to send the patient to Dr. Subramaniam Iyer.
I think that's not a good solution. If you say send him to your worst enemy, but well, I have no enemies. No, but well, you can try to maybe do an alloplastic mandible, but in cancer cases that's very difficult. I did one case a couple of years ago where the patient had an avascular disease where the whole mandible had gone, and we used an alloplastic mandible together with fossae, and it was made out of titanium, also planned virtually, and that went well over 6 years until the patient died from lung cancer. But I don't think that is possible in a cancer case with possible irradiation and things like that. I would do it in an ameloblastoma maybe or something like that, but not in a cancer case.
Yes, sir. In these kind of difficult cases, somebody was talking.
No. I just was asking, is there any like irradiated rib where we use it for the nose augmentation? Can we use anything similar to that for the mandible?
It's like allograft.
Yeah. Irradiated one?
No, it won't stay.
Won't stay.
Won't stay. Mandible is a very mobile bone. It requires something vascularized. It won't stay.
I don't quite agree. In a limited defect, you can use, of course, frozen allogenic bone to augment the mandible. So
that's augmenting the mandible, not replacing the mandible.
Making the vertical height of the
no, that is different. What he's asking is, can you put a mandible allograft?
Yeah.
I was discussing on this. Iyer sir is working on tissue engineering as well. So how do you see the future? Is it going, because we have so many issues or so many difficult situations? Will that?
If you look at the way tissue engineering has been published, there was only one good article, good sort of thing which came out a few years back. After that, nothing has come.
No, but there are some maxillofacial surgeons in San Francisco or somewhere. Last webinar somewhere they presented a tissue engineered mandible, like what Professor Carl Peter had showed, that titanium mesh packed with bone grafts, then stem cells and whatnot. And
see, the paper from Scandinavia, which
Germany.
Yeah, yeah. That was very good. They had, the main problem is a remote vascularization. We have to have it in a vascular carrier, which maxilla and mandible had been demonstrated to be there, but the way it was made in what you call the the facility to be used for making it, I think it is not a very practical solution at present, but technology might be okay.
They prefabricate these grafts or transplants underneath.
I mean, then the only answer is an transplant. But then transplant, you will require immunosuppression.
Yeah, that takes several operations to get it created.
Let's hope we don't fail all two fibulas and the scapula also and the iliac crest also.
Yeah, I think these are very experimental methods which cannot be generalized or cannot be recommended for generalized use. And well, you never know what happens after these operations. They just show you the immediate results, and you never know what happens after a few years.
Yes,
that's at least my experience. If these are really constant results, I don't think so. Many times, I'm sorry to say that, but I just don't believe it. To be honest.
Maybe still we'll have all the ribs option open.
Yeah, sure.
Vascularized rib grafts.
Yeah.
The last option.
Yeah.
I think if we are worried about complications or problems, we will most of these challenges cannot be taken, isn't it, Dr. Shin?
No, somewhere we have to face it. Out of that only we will learn, so others they don't have to go through that.
Yeah, I agree.
Any questions in the chat box, Dr. Vidya?
Yeah, I had asked a question personally, in the sense like at Amrita we used to flush hepsaline into artery before doing the anastomosis, isn't it?
No.
It should not be done.
We don't do it. We just use it as a irrigation while taking the bites through it and just see the wash the end. Otherwise, you don't have to really flush the flap with heparin unless you suspect that there is some clot when you keep it up. There's no need.
But
initially, I used to do it, but I don't do it now.
Doesn't it help in washing out the two things which I found useful was, one, it would wash out, because anyway we would be doing after some time, there would be some washout of some of the clots which are there. Second is that we for sure know that the vein is draining it nicely, and that is the vein too. If you want to choose a vein.
I mean, if you find a clot there, when you when we divide the idea, what I do is we clip the veins on both sides, and then veins are clipped when you divide, and the artery is left open on the flap side. So the venous system stays full, and the artery is open, and your pedicle dissection becomes much easy with the vein full. When the vein is deflated, to separate the artery and vein becomes little difficult, specifically in fibula where there is so much of cross incision is there between the veins. And when you open the clip, the blood flows. If you find that there is some clot or something, then you irrigate it with heparin solution. Otherwise, as a standard procedure for each flap, we don't do it.
Yeah, Sajid. So I think I answered others also. We don't use flushing of artery with heparin and saline. I think there are two problems which I will be really suspicious about or critical about. One is damaging my intima when I'm flushing it with a saline, and second, undue pressure. You don't know how much pressure you want to actually push inside, so it can actually cause damage to your intima. And we do artery first, so when you do artery, you automatically know what is the venous outflow, and then you can choose your vein, which vein you want to do. So maybe it is helping. I think it is individualized choice.
But do you clamp the artery then after, or just how do you do that when you go for artery first and let it flow, and then.
So there are usually two veins. So when I'm doing one vein, I keep the artery open. I do the one vein and I keep the another vein open. That's how I do it.
Okay, but you lose a lot of blood, maybe.
Yeah. No, many people keep the artery clamped. Whoever does the artery, I have my colleague who does artery first, and then one clamp stays on the artery, and once you do the vein, then only releases the artery. But given a choice, I like to do vein first because then you don't have to put a clamp on it, and then you do the artery. So automatically you don't have to, because sometimes the artery doesn't like to be clamped for a long time and doesn't want to flow then you have to pamper it a little with warm saline, lignocaine, papaverine, and all that.
What is your experience with saphenous loops to get a longer pedicle?
Where you can use it. If you're required, yes, you will use it.
Yeah,
but very
no
rarely you will require vein grafts.
But how do you try to make them safer?
Which one?
The loop, the arteriovenous loop. Do you put it to the recipient vessels first and let it flow, and then go for the anastomosis with
yes, because once they become full, they will lengthen in the size. Okay. So that's better, and then do it to the flat vessel.
Okay.
Unless you are doing a bench surgery. On tables, you will make the loop, lengthen it, and then join it to the vessels.
Okay.
I don't know what others are doing.
Well, the other way is to put it to the flap first and then divide the lower end and put it to the recipient vessels.
I think both ways you can do. In that case, you do artery first, so the vein usually lengthens. So you can't have much longer length of the vein.
Sorry, please go ahead.
No, I think whatever is convenient at that time to do it, I think that's the solution. Yes. Because it's very rare occasions that you have to increase the artery and vein in the head and neck position.
I've seen some surgeons.
In German, there's a nice sentence. It says, if you are successful, you do the right thing. Or you have done the right thing.
Everybody develops their own habits and their own algorithms. Once you start doing more and more, what you are comfortable with.
You giving a hepsaline after doing your artery. At last bite of your artery, you give heparin, 5,000 units.
No.
And then later, open the artery, again clamp the artery, and do the vein. Isn't it, Harisa?
Some practices.
Yeah, we used to do like that at MCC.
Okay.
So,
as somebody was saying, as we grow experience, we lose some of these habits which we carry on.
No, that's what I'm saying. You do more and more, then you will have your own reasoning and your own comfort levels.
Most of them are not evidence-based though.
Yeah, that's your self-evidence.
Dr. Srinivasan, many times, I think everyone would be agreeing that whenever we hear a prosthodontist speaking, next fibula case, we'll be ready for dental implant, and then we'll do all sorts of things to do that. But finally, we will come to the same point, back to zero. But I think all head and neck surgeon would agree to that. How successful are you, Dr. Srinivasan?
How successful am I in what? I didn't get
in prosthetics, in your forgotten patients.
Yeah, I think this is a crowd full of surgeons, so I have to be very careful in what I say. So, but I think, I mean, to be fair, I think the more I enter the OT, the more I am far more receptive to what the surgeons say and sensitive to what they say. And I always keep hoping that the vice versa is true as well. So I think I've been trying to do this for over a decade and a half now. And over the years, I'm seeing an increasing lot of surgeons who are more and more receptive to what a prosthodontist is willing to tell them, and probably adhere to it. So I try my best to keep suggesting that it has to be prosthetically driven all the time. And after every talk, I think if we have one surgeon converting to that idea, I think over the next 10 years, we would have many, many more people.
No, I don't think it is surgeon dependent. It is patient dependent, because we always tell patient that it is possible to osseointegrate if there are corresponding teeth are there or the joint is there. But many times, most of the times, patients are not willing that we will see it afterwards. Maybe the cost comes in the way or something, I don't know.
We don't know that.
But if we can do it, then the dental rehabilitation phase reduces like anything. If you have done the primary dental implant.
Ma'am, I would say, I would put this dental rehabilitation, the main culprit is not surgeon or prosthodontist, is the radiation. Simple fact.
No,
Simple
but
fact of that radiation is there. You see, ameloblastomas, you don't have a second thought now. They all go into dental rehabilitation as primary or secondary or a denture base, whatever it is. There's no problem.
no.
But in mandibular reconstruction for cancer, you always are worried, even later on also because of the radiation. You are thinking twice. Should you inflict more issues and then cause some problems for the patients? You are not confident in telling the patients, okay, go ahead. When the patient comes, that is also a fact, which is very difficult.
No, but if patient is willing and you are also willing, if we put it, the dental rehabilitation phase reduces like anything.
Yes.
Because
It is
if you
correct,
don't
it's
put it
correct.
primarily, then you cannot touch the board for minimum 1 year.
Yeah, correct. The primary we have been trying, see, but the problem is that, see, it's not that as
It's not that
smooth
straightforward.
and silky
Yes.
as thing.
Post RT, how tissues will move and what patient will have the enthusiasm to go through afterwards.
Correct,
also we don't know.
Correct.
It's always difficult. I think it was never meant to be easy, but it's just that given the pros and cons, sometimes you may decide. I think it's again something which has to follow discussion pre-operatively. I think my stress is always on to discuss the same pre-operatively rather than later, because I've worked in institutions and also in private practice, and I've realized that the decision-making process is a bit different in both of them, and that also sometimes influences the choices that are made. Sometimes
I would say that if you have to make it a practice that all these patients who undergo radiation receive a implant based denture, the pre-RT implantation might be the way to go forward. But again, you cannot generalize it. You have to take those cases so much with great caution and then make it successful. Don't lose even one. Then you get disheartened, right? Everybody does. So when you're doing that, when you're embarking on that, I would say put all your efforts on the soft tissue reconstruction, giving the good flap and making sure that it all is covered. And the radiation oncologist also knows these things. So I think we have to put a lot of effort to get it right, to make it a standard practice. Otherwise, if everybody starts doing just like that, you will fail lot of cases, lot of times, and it will just die off.
May I ask about the percentage of patients in India who request dental implants after a reconstruction of the mandible, a bony reconstruction? Because in my experience in Germany, it's about 40% only. The others,
not even 40% here. In 100 patients, maybe
five,
only three,
four,
5 patients will ask.
5%.
Yeah, okay.
Malignancy.
In absolute numbers in India, that's much more than in Germany. But
but we are talking about cancers. We are talking about cancers.
Yeah, I talk about cancer. Only cancer patients. And well,
I don't know in Germany whether it is a national health scheme in Germany.
I think we have a completely different cohort of patients, because usually there are elderly patients and not young patients. They are from 55 to 60 onwards, and they are severely ill mostly. So they are suffering from, I don't know, from lung disease, from diabetes, from things like that, multimorbid patients, and those patients usually are very glad if they survive, and that's why they just don't ask for implants, which would require another operation and another surgery and another expense on their own, because that is not covered by our health system.
Yeah,
Yeah,
for
I think
here also the patient pays for everything.
right.
He has to, and post RT, he has so many problems by that time. He has so much expenditure. So I think his enthusiasm of going ahead with osteointegration,
That is
rehabilitation
different in our
reduces.
country.
And if the price comes down, people will not use it. I think so.
The patients usually get paid for the resection and the reconstruction and intensive care unit and everything like that, but not for adjuncts like implants.
Yeah.
For us, it's a completely different ball game. It's NHS. It's totally free, and
Yeah, there
we
it
have
is.
actually, and 95% we have to achieve in our cancer board meeting. Prosthodontists, they play a big role, and it's all fully kind of covered. So it's different in NHS.
I think financial considerations play significantly influence. I think even at least in our country, because I'm in the private sector, so I have often seen patients not going in for implants primarily purely because of financial considerations, because they would rather save their money for any adjuvant treatment if required.
Yeah,
and
nee,
then
that's what I'm saying. Patients are paying from their pockets.
pockets.
So they have a lot of expenditure afterwards. And again, you will call them every 3 months, every 6 months, every 1 year for follow-up. That coming, going, I think that's a lot of burden. So
And
money
also,
does play, and it does play a role.
True, but having said that, ma'am, for the small subset of the population that we eventually end up addressing, and if we are able to do a reasonable job for them, I think they understand the value. But it's a huge challenge, especially with so many factors coming into play. So
also, I think I mean, the IMRT is a standard of practice in everywhere in UK and most of the cases. That is intensity modulated radiation therapy. The side effects are much lesser than the conventional radiotherapy. A good oncologist can plan how much doses to give, where exactly. So that's where the multidisciplinary team meeting that could significantly minimize the radiation-induced complications.
But same thing is happening here also.
Yeah.
So Dr. Jay and Dr. Kal, I think this is a very good point which you have raised. I just wanted to know that we do discuss with our radiation oncologist also, and we pursue them to distribute the dose, but still they just want to bombard that same area with same 60 gray, thinking that this is the primary nidus of the tumor. And we say that the tumor is out now. You don't need to bombard my flap. But are you able to convince your radiation oncologist to change the fields in some way, Dr. Kal and Dr. Jay?
I didn't get the last sentence.
So is there a difference in planning of radiation, adjuvant radiation, to this patients in
I think
when
my
the
ex was
See, what we always say is what we reconstruct and send it to the radiation, and what they give it back to us is very different.
Sorry, it's breaking. Yeah.
What we reconstruct and send it to the radiation oncologist, and what he sends it back is very different.
Yeah.
No, we do the decision after the surgery. That depends on the extent of the free margins in oral cancer.
Okay.
And if that is less than 10 millimeters, we sometimes reoperate just to go for more extended margins, and the radiologist, the radiologic oncologist, well, he makes a suggestion depending on the neck, on the lymph node status, and also on the margins and the extent of the tumor and the general status of the mucosa. If there are other dysplasias which you cannot just dissect because they are far spread and omnipresent in the mouse, you go for radiation. These are the reasons. It's not dependent on the idea if I'm going to put implants or not.
So the field mapping doesn't change.
Please
repeat. So the field mapping for the radiation doesn't change with the implant.
No.
No.
We never do the implants prior to the irradiation. No. We
do it. That doesn't, but that doesn't change the radiation. How our plates and screws tolerate radiation, like that the implant will get integrated.
I know the work from the US, mainly from Mark Erkin and others, and Daniel Buchbinder, who have claimed that it's better to put in the implants prior to the irradiation, but according to our system of finances, it's simply not possible to do that. Even if we are a high income country, that is not cared for. I'm sorry to say that.
Dr. Jayant, anything more to?
We are coming to the conclusion session of this reconstructive series. I thank all the speakers, Professor Subramanian Iyer, Madam Prabha Yadav, Madam, Professor Carl Peters, Jay, Dushyant, Dr. Srinivasan, everyone for this excellent talk. And I also thank all the speakers who made this webinar, reconstructive webinar series, a very successful one and very useful. We thought we had, that is from basics to advanced, we want to cover, and it was done in this 5 weeks. And I special thanks to Dr. Iyer sir, Vidyadharan, Sajid sir, Divagar, Adarsh, and Subhash, our focus team, whole of the focus team, and for this making this event very successful and useful for all upcoming people. Thanks a lot. We had a very great day, and next month we are starting on rhinoplasty series. So we have 6 series. That is, we have finished trauma, we finish reconstructive by today. Next month, December, we have full rhinoplasty, then craniofacial in January, and we have aesthetic and aesthetic surgery in February and March. So 6 months program starting from
great.
Every
Congratulations.
Thank
for
you.
Conducting such programs.
Thank you.
Big program. I think it's Jayan's brain and then Jayan's effort. Congratulations, Jayan. We'll try to chip in also.
Great.
All the best.
Thanks a lot. Thank you, sir.
Thank you all.
Thank you all.
Thank you, everyone.
Take part, and thank you again for having me.
Thank you. Thank you, sir.
Thank you
for calling us over. Thank you.
Right.